Stefan Johansson with the Wyoming Department of Health. It's good to be with you this morning. As requested, we will give a brief overview of the behavioral health redesign project, primarily the work that has transpired over the summer. But just as a quick reminder, nearly 2 years ago, or actually a little more than 2 years ago, the legislature passed a bill that authorized the department or directed the department to transform and redesign and reform our community mental health and substance abuse system, the funding that goes with it, and the populations that are served at our community mental health centers around the state. Not a new topic to this committee, but there are some new facets to what have been what I think is good work from the stakeholder group and multiple departments in this final year of the design and implementation of the behavioral health redesign, which by statute will take effect on July 1st of next year. So with that, I'm joined on my left by Matt Petrie, who is the Senior Administrator of our Behavioral Health Division, oversees the Community Mental Health and Substance Abuse Centers, as well as our Wyoming State Hospital and Wyoming Life Resource Center. And to my right, Franz Fuchs, who is our Chief Policy and Data Analyst, and has really been spearheading with all of the stakeholder groups this behavioral health redesign effort, which I'm pleased to say is moving along well, and we're on track for the required implementation by July 1st of next year. With that, Mr. Chairman, unless there's any initial or general questions, I'll hand it over to Mr. Fuchs to get us started.
Very good, Mr. Fuchs.
Thank you, Director. Good morning, Mr. Chair, Mr. Co-Chair, members of the committee. My name is Franz Fuchs, Policy Analyst, Department of Health. Starting with slide 1 from our omnibus presentation, I think the LSO has it up projected up there, and you have it in your packet. I'll just kind of gloss through this presentation pretty quickly. I think most of you are familiar with this. I know I gave this similar elements of this presentation to some of you before, but I'd like to focus more on the potential legislation, the proposed legislation that came out of the Mental Health Vulnerable Adult Task Force at sort of the tail end of these slides, as well as leave time for any questions. So just moving right along, slide 2, why are we here? Why are we doing this? This is really about, changing how we procure behavioral health services at the state level. So we spend about $100 million a biennium in general fund. This is one of our biggest budget line items, period, in our department. And really, historically, this has gone towards providing general access mental health services to a wide population throughout the state. Back in a time when there really wasn't many behavioral health services aside from the state hospital and the hospital in Cheyenne. So that's kind of been the historic mission. And the idea is really kind of shifting, not necessarily adding or subtracting from that total amount, but shifting how we buy those services and what we're buying as a state. So we're really trying to reconcile that tension, right? We have this access to a general public, and we have also a lot of high needs folks, people coming out of the state hospital, people coming out of Rollins, people coming out of Department of Family Services, institutional care, that may fall through the cracks. And so we, as a state, tend to rely heavily on institutional care, and we're trying to kind of move away from that. And so a big part of this procurement effort is sort of moving that priority away from general access and towards focusing on sort of these high needs populations that are really costing the state and in terms of time and effort and money in institutional settings. The slide or the next slide kind of just shows a flow of kind of total behavioral health funding that we see. So this BHR focus is really that top the top right there. It's a pretty significant chunk. This is on an annual basis, so $50 million, $100 million a biennium. But you can see the rest of the context, right? How much we spend on PRTFs, other Medicaid behavioral health providers, psychiatric hospitals, and the state hospital, and so on. Kind of moving to say slide 6, just skipping through this presentation. Really, what's the goal here? The goal with this procurement is we really want people in state institutions to be actively pulled towards community settings. We don't want the state hospital really trying to push people out and trying to discharge them and find placement for them. We want providers in the community to be hungry and really want those people in their care and actively pulling them out. That's really the goal. And that means if we're not, stuck with people that are ready for discharge, but we can't find a placement for them, they're taking up a bed at the state hospital. And the longer those beds take to turn over, the less our effective capacity at the state hospital. And you see our wait lists on Title 25 build, our costs in Title 25 mount. And it's not just us. Department of Corrections has the same issue with prisoners in Rollins. The more recidivism there is, when they release prisoners that are high risk for recidivism, if they come back in 2 years, That's another bed that's filled in Rollins, and they are shipping prisoners out of state to deal with that overcapacity problem, and that costs the state on a marginal basis. So the idea really is those marginal costs, right? The costs that aren't necessarily fixed. We're going to have a state hospital. We're going to have to pay for those employees regardless, right? But the costs that are outside of that for the wait list, those are really costs that can be potentially saved if this reform is successful. And I think other agencies like DFS and DOC would say the same thing. We want people with high needs to not fall through the cracks. So at the end of the day, when someone's discharged, we want someone to be actively caring about them in that community and caring about their welfare. And ideally that will prevent them from going back and cycling through the system again. And at the end of the day, paying for what the state wants, right? So currently we, on the block grant basis, we're again focusing on that general access. We pay for general hours of service to anybody. And that's sort of, how it's been reimbursed in the past, and sort of shifting away from that to really focusing on these priority populations. So the summer of 2021, 2022, going through these slides, we focused on a variety of things trying to execute the statute. Eligibility, outcomes, transitions, payment was a really big focus, obviously, since it's about procurement. At the end of the day, a contractual, how we write a contract. You can kind of see how the dollars are shifting there. I'm happy to take any questions, but I would I'm kind of going for speed here. I know the agenda is very busy. So if you want me to slow down or have any questions, Mr. Chair,
I think I see a question down at the end of the table. Senator Hutchins.
Thank you, Mr. Chair. Franz, on slide 6, and I could be wrong, and please let me know. We're talking about money, how much it's costing the state, and we want to get people out of the hospital into the community. What I'm wondering is, what is going on in these hospitals that is helping the people get to the point where they can be released? You have all these new drugs, you have a lackadaisical attitude about life and all that stuff now with these young people and even older people, and we're seeing it everywhere. How are you getting them to the point where they can get out and stop costing the state money? It seems like you have to kind of work together on that, but it seems like this is so focused on money. Can you answer that?
Mr. Chairman, Senator Hutchings, you're absolutely right. This is a two-sided effort, and we definitely are making efforts on our side, on the institutional side, to prepare people for discharge. I would say that the clientele at the state hospital, substance abuse is not probably the primary issue there. It's really significant behavioral health challenges, which can be managed and through medication, and people can be stabilized and be ready for discharge to a lower level of care. And the state hospital is really the tippy top of the pyramid, right? And we want people to be there for as long as medically necessary, but not any longer. And we found ourselves in the past where people may be fine to be discharged to a community provider, but we just can't find a placement for them in the community. And so really it's trying to incentivize that other side, really to pull those people out when they are ready, and not trying to push people out before they are ready, but work together. And but you're absolutely right. It's a partnership.
Very good. Proceed.
So the main realignment of the payment on slide 8, you kind of see, how things are currently procured. We have sort of a mixture of residential beds that we pay for those beds. We have outpatient service hours that we pay for. And then we also have these base payments that like lights on, doors open type payments. And that's the graph on the left, the pie chart on slide 8. And what we're shifting to, generally speaking, is expanding the base payments. So now that's 40%, combining the residential and outpatient into one kind of general bucket of service payments, which is that 50%. And then reserving 10% of this pie for kind of an innovative approach that we believe is innovative, paying for outcomes. And that really is kind of socially desirable outcomes for really the highest need folks. And so those would be things like, someone's released from the state hospital. When a community provider agrees to take them, we will pay that provider every month for success if that person is housed, engaged in the community, whether they're employed or volunteering or just getting out of the house, and engage in their treatment. We want them to be successful in their life outcomes, and we would reward the providers on a monthly basis for the success of that individual person. And that's really the idea with the outcomes payments. And that money is at risk. So if they're not housed, if they're not employed, if they're not engaged in their community, the provider would not get paid. So we're literally paying for what we want. There's obviously a lot of complexity with that. There's a lot of risk on the provider side, and we appreciate it's been a significant dialogue with them trying to figure out that balance. So there are some safeguards for them. We don't want to ruin the providers, obviously. So there are some safeguards, for example, like on slide 11, you can see the third bullet there, the hold harmless provision, where if they take outcomes risk, if they take on these clients, but they don't succeed in those outcomes, we will credit that lost amount or that potential at risk towards their service payments later. So they'll be able to kind of draw down that money later through billing by services. This is all pretty complex to kind of go over in a short presentation, but it has been a really productive and very good dialogue with the community behavioral health centers and trying to really figure out these tensions of how much risk do we put on them, how much risk is on the state, how much do we really balance out the system, particularly when we're changing everything at once. You know, a lot of these provisions are changing, you know, the populations are changing, the service payments are changing. So we really want to minimize the risk to the system when we jostle, you know, we're moving during this transition. This current summer, we've been really focusing on a lot of the bureaucratic nuts and bolts. So for example, eligibility, the benefit design, those involve a lot of vendors. We contract, Wyoming Medicaid, you know, has vendors that do these systems, right? So we have to prepare now to write those contracts so they can be executed in the fall. And so the vendor has time to make those system changes by the winter. So we have time to start, you know, enrolling, going through the eligibility screening process in the spring, right, for a turn on in July. So it's a very long lead time. And we've really been focused on these kind of particular moving parts the past few months. We do have a lot of work to go, but at the end of the day, I think we're in a pretty good spot, as the director mentioned. And I'm sorry, we're still on slide 12. I was going to transition to kind of the bill piece in a minute, but let me just pause here and see if there's any questions generally on the past slide deck or on the reform.
Any questions, committee? Seeing none. Go ahead.
So that brings me to the draft legislation that you'll consider, I believe, second. So this is the 24 LSO 0116 behavioral health redesign amendments. And we just kind of want to walk through the rationale for why we are requesting this and why we requested it through the mental health vulnerable task force.
I think what we'll do is we'll go through actually both of these drafts and then come back to public comment, but let's go through both drafts while you're going through them because they're both short.
Mr. Chairman, do you want me to just go through this deck real quick? And then
no, this would be fine. Go ahead, proceed.
So the main issue, the problem we're really trying to deal with here is this definition, including insurance coverage in the lowest tier of priority populations. So of the priority population, there's multiple tiers, right? There's people coming out of the state hospital. There's people involved in state level justice. There's high needs kids and families. At the very bottom of the tier or the bottom level is these indigent general access clients. So this is pretty much anybody else who is below 200% of the poverty level. And as you can see in bold, who does not have private or public health insurance that provides coverage for mental illness or substance use disorder treatment. The proposed legislation would take out that bolded section. And the reason is including insurance coverage in the eligibility portion is a very broad sort of sledgehammer based approach towards this issue. Insurance coverage can be pretty variable. Some insurance plans pay for certain things and not other things. Medicaid, for example, does not cover residential services. So there are current people on Medicaid who are receiving residential treatment on the state general fund dollar. And those people would no longer be eligible if this statute goes into effect in July. And we are prepared to execute the statute, of course, but we want to let you all know and let you know, have the opportunity to make the decision, is this the right policy for the state? We believe this is a bit of a problem because, we'll create a disruption for some people, right? They may no longer receive the care they need. But we also think there's a better way to deal with this. And that's really kind of putting down the sledgehammer and picking up a scalpel. And the scalpel really is dealing with insurance coverage on the claims level. So people may be eligible for services, but then we examine the claims and the individual services people receive, and we see whether or not insurance could have covered that or would have paid for it. And we deal with it then. So what this bill does is it strikes out the language on insurance coverage in the eligibility portion. And then it basically adds a session law on what the department should do with what we call third-party liability. And this essentially deals with insurance payments, potential other third-party payers on the individual claims level. There we had a couple options. And the real problem we're facing right now is we don't know which option to recommend. We don't know exactly, for example, how many people, because the system has operated on a block grant basis. we haven't run everybody through sort of checking on their insurance coverage. So we don't really know the magnitude of the potential savings that could be available, right? We don't know. So the real idea with the session law that you'll see is kind of studying the issue. So just pause. Let's keep business as usual. We tell the providers that they really should check for insurance and bill that insurance when necessary. But when the state receives a claim, we will pay it. That's kind of what we'll do. So that maintains status quo. So the con of that is there may not be efficiencies that to be gained, but it's not like we would lose any more money than we are currently, right? It's just sort of a cost of lost opportunity. That's the con. The pro is that we would have time to study the issue, come back next year and say, here's the magnitude of potential savings that we could recoup from these various methods. And here's the method we recommend. And legislature, we recommend this option, and then you, as electeds, you all can make the decision on which TPL method we could pursue. Those two options, generally speaking, will be either option A on slide 15 or option B on slide 16, or a combination of both. And I'll just run those really quickly just for your situational awareness. Cost avoidance is the default. It's what Medicaid does now. Basically, the idea is that providers are supposed to bill primary insurance. If they don't, if the provider bills the state first, and we know that that person has those benefits, we will deny the claim and say, okay, go bill that primary insurance. So it's cost avoidance because we're not paying the cost to begin with. This is administratively easier for the state. It's what we do now. It works for everybody in the system currently, all insurers, Medicare. But what it does is it puts a little bit more administrative load on the providers, right? They're going to be now responsible for billing that insurer and making sure that they're recouping those funds. It also potentially, given the behavioral health needs of this population, there's going to be a lot of people with extremely high needs. This could also potentially create barriers for them, right? If someone's coming out of the state hospital and has a employer-sponsored plan, say with a $5,000 deductible, and they go to the community mental health center for treatment, and we say, hey, you have insurance, go bill that insurance. But now, of course, they have that $5,000 deductible to meet. That might be a barrier for them receiving treatment at that community level. And of course, then they may decompensate and end up back at the state hospital, right? So there's a potential that the savings from the state may be exceeded by that institutional cost, right? If we create those barriers. We don't know exactly how that's going to balance out. So that's why we're asking for this third option, which is punt and study, we call. The pay and chase option B is really where providers, if they bill the state first, we would pay the claim, but then we'd look up coverage for the member and say, okay, you were covered by, say, Blue Cross. We would itemize all those bills that we received that Blue Cross owes us, and we'd send the bill to Blue Cross as the state and recoup the money from them. That's really the goal. This is a very novel approach. It's not done in large degree now. It'd be very there'd be a lot of adaptation for insurance companies, and in certain cases like Medicare, it wouldn't work at all. Medicare would never accept just a bulk billing from the state from this. They require the cost avoidance methodology. But the advantage is it does create more of a seamless care model, right? So again, going back to that person in the state hospital, coming out of the state hospital, we would pay those claims for that behavioral health center. They would receive that care, and then we would try to recoup or figure out who's liable for what cost, whether it's the person or the insurance plan, and there's a whole host of questions there, like if the person has a $5,000 deductible, how much should they be liable for that if they're extremely high needs, right? There's a lot of policy questions that are unanswered. It's significantly higher administrative work for the state to build this system. And we don't know if the juice is worth the squeeze. Are the recoveries we're going to get from this actually worth the cost of building the machinery to do this? We just don't know the answer to that question. And again, it's not really standard practice. So pros and cons to both these options. What we're requesting in this bill is, again, just, hey, let's keep things going as they've been going for at least for a year. We'll study how things we'll identify potential recoveries that we and report back to the legislature in a year. Here's a recommendation, and you all can proceed with that recommendation in time. So that just is a quick explanation of that particular bill draft.
Any questions on this portion? Senator Hutchins.
Thank you, Mr. Chair. Franz, going back to the, I think it was 13. Yeah, 13, 14. First of all, why was this definition put in there like that on slide number 13, the bold?
Mr. Chairman, Senator Hutchins, when we were
history.
Right. So this was a couple years ago when we were drafting this initially. We really wanted to focus the eligibility on people that were uninsured. The thought was that there is fairly generous insurance coverage on the marketplace that could cover a lot of behavioral health conditions. It's only been since we've been working through all the details of the implementation that we're noticing all these complications that are kind of coming out of the woodwork of, oh, Medicaid, when we see somebody eligible, as we're working through this eligibility structure and that you see in the BHR report, right? Designing everything, all these questions are coming up from the vendors saying, hey, how do we do this? What happens at this decision point? If they're covered by insurance, what eligibility group you want to put them on? So that's been all the details has been raising all these questions. And so that's where this kind of problem came up, if that makes sense. So it really was, unfortunately, the devil's in the details, and that's coming out now.
Follow up, Senator Hutchins.
Thank you. So is it mainly Medicaid people that we're having this issue with? All Medicaid, nobody else?
Mr. Chairman, Senator Hutchins, this would cover anybody with, in theory, with Medicaid, but also there's a lot of people with private insurance, right? On the exchange, people are eligible for extremely subsidized plans between 100% and 200% of poverty. So there will be some people that may be affected on the private market too.
Follow up, Senator
Thank
Hutchins.
you. Is that where you keep getting this $5,000 deductibles? Kind of like, or is that just something you're throwing out? It could be $200, it could be $500, but you're just throwing out 500, that 5,000.
Mr. Chairman, Senator Hutchins, that's just a corner case that we, just an illustrative example. Yeah, that might be, we don't know how many people have what deductibles right now because people haven't been processed through this eligibility system yet. So a lot of this information is just unknown. Because we pay for all this on a block grant basis now, the amount of information we have on these clients is limited.
Okay, one more.
Follow up.
One more question. I keep hearing you say, and again, I could be wrong, we'll do status quo. We'll take this definition out, but we'll do things just like it's in there still. Why take it out now? Why don't you just do your study, find out what'll happen, and then come back later to have us remove that if need be?
Mr. Chairman, Senator Hutchings, so the statute language does require the state to be the payer of last resort. So if nothing changes to the statute as written, we are prepared to execute it. And that means that we will do cost avoidance methodology as the default. So when Medicaid system processes these claims, we will deny them and we'll ask the provider to bill the private insurance. And we also will exclude anybody who has insurance coverage from eligibility in this tier. Now, someone may be in a higher tier and have insurance coverage. And because this only applies to the lowest tier, they still may receive general fund services, right? If they're in a tier 1 or tier 2, but this tier 3 specifically, those folks will lose the general fund benefit if we execute the statute as written.
Okay, thank you.
Very good for the questions. Representative.
Thank you, Mr. Chairman. So one of the concerns that I'm having as I'm listening to this is, as the state accepts greater responsibility to then cover these different populations, or these populations that haven't previously been covered, I have concern that gives insurance companies then an out to say, oh, well, the state's going to pick this up, so we're not going to cover this anymore. Do you anticipate that becoming an issue?
Mr. Fuchs.
Mr. Chairman, Representative Penn, I think not really. The reason is because, one, these are priority populations are already eligible for these services, right? So anyone coming from the state hospital can receive these general fund services now because it's open access. Anybody can get them. What we're doing is necking down the population that can receive these general fund services. So we're prioritizing. So it's less people that can receive the services in the future than can net today. The second thing is most of these people probably aren't insured. We haven't expanded Medicaid, so and most of them would probably be in that coverage gap. People with really high behavioral health needs, may not have insurance at all. So I think the insurance coverage for this population is pretty low on a baseline basis. And the benefits that insurance, there is technically mental health parity in the insurance market, but that's not, the benefits aren't as robust as some of the state general fund benefits. Like residential treatment is not, universally covered for all insurances and so on. So for those reasons, I don't think there'd be much of an impact on the insurance companies. And it's particularly if we actually implement really strict third-party liability, right? provisions. We, by hooking up that system, which we already have for Medicaid, to this general fund system, we'll be able to identify more potential third-party liability and potentially, so insurers may actually be on the hook for more once the system is fully operational.
Follow up, Representative Penn.
Thank you, Mr. Chairman. You said that this is necking down the eligibility. I was under the impression that it seemed to be the opposite. It looked like we're removing some of the qualifiers to who would be eligible for this. So maybe I'm just misunderstanding. Could you explain that for me a little better then?
Mr. Chairman, Representative Penn. So you're right, this bill would expand it a little bit from where the statute's going in 2024. But I guess I was referring to currently. So with the block grant model, eligibility is open-ended on a sliding fee scale. So you and I can go receive these services, right? And we'd have to pay more maybe on the slide, but we're eligible for those services now. When the statute goes into effect in July 1st, 2024, the priority populations are the only ones that can receive services under the general fund dollar. So that necks it down significantly. If this bill is passed, it opens it up a little bit more by removing that insurance provision. So it's kind of both ways, if that makes sense, just depending on how you look at it.
I see one more follow-up there. Go ahead, Representative.
Thank you. So this on slide 13 with the definition, so that current definition is not what we're dealing with now. That won't take effect until next year. And so we're trying to alter that definition before it takes effect.
Mr. Chairman, Representative, that's correct. Yeah.
Gotcha.
Pretty good. Mr. Chairman.
Thanks, Mr. Co-Chairman. Maybe just some background for the committee, and I'm going to overly simplify it, but because I have a lot of new members, how this process works, and maybe we didn't talk about it enough. So this is a bill from 3 years ago that was going to be a 3-year project, goes into effect next year. Concurrently, we had the Mental Health and Vulnerable Adult Task Force, which has been studying the issue and working on these pieces of legislation for 4 meetings, but they don't have the authority to bring bills to session. So it's somewhat perfunctory. They come before us, we ask them questions, we can change them certainly, but know that this idea and the bills have been studied before us extensively. They just have to be sponsored by a committee. I think there's 8 bills and these 2 came to Labor Health. Back to this bill at hand. So the issue, and I'm going to oversimplify it, is this new design. We're spending $100 million by annum, $50 million a year state general fund on behavioral health services, which everybody agrees is way too much. And we got to find a way to be A, more efficient, and B, less expensive. So we had this kind of innovative first in the country plan, which we're all hoping is going to work, that really the Department of Health is masterminded. And so we've got to this point where there's a couple of options. And option A, the difficulty is it's probably not going to make this whole thing we've been doing effective, because you go and say, hey, this person, they get out of the state hospital or out of a county jail and they say, hey, well, you actually do have insurance and we're going to bill it. But then, you know, somewhere in their insurance, fine language, they don't actually have coverage for mental health or substance abuse. But it takes 30 days. And in those 30 days, that population is having problems and they're getting re-incarcerated, recommitted, having manic episodes, you name it. We're not solving the problem. Option B means the state is just going to kind of cover everything up front, which is probably how the program would work amazingly well, but it's expensive. And once you start that step, you're probably never going to get us to move away from the state kind of being the first payer and trying to recoup money on the end, which I don't think we're going to sell in the legislature. So option C is, we keep calling it the punt, but I like to call it the more study, get the costs down exactly, and try to figure out better ways once the system starts working to say, here's how we're going to do it long term once we have a better idea of the finances. And so I know there's option A and B. C is probably the preferred way for me and the Mental Health Vulnerable Adult Committee, because this is kind of the biggest innovative thing we've done in a century in behavioral health, maybe in the country. We don't have all the answers, but we need to keep studying it. So that's kind of the question before you. A is going to make this whole thing we've been doing kind of not as effective as anybody hopes. B is going to make it very expensive. It'll probably work wonderfully, but the state's on the hook to be the first payer. C is the study option. So know that we've discussed, Senator Baldwin and I have been on this. He's one of the co-chairs of mental health and vulnerable adults, and he's worked on this for 4 years. We're kind of at the last step today to just have a committee sponsor it. And we're happy to answer any questions. Department of Health has been 3 years every week probably on this. But that's kind of the background on where we are today and why the different options are before you. Thank you for letting me clear that up.
Representative Chen.
Thank you, Mr. Chairman. Just to provide some context for some of the new members, the bill that was passed in 2021, if you look at slide 5, talks about, which is what Department of Health is saying, shrinking from the general access population to these 4 priority populations. And so then what the task force did was, and what we had in the bill actually was that we knew that this was going to be very complicated, that there will probably be some issues that we need to iron out on the way there. So while we're trying to figure it out, we're going to set this timeline where in 2024 is when we actually set it into motion. And so we have this time in between 2021 and 2024 to really think about all the details and fix the process before it goes into effect. And so one of the bill that's being proposed as the amendment is really to tweak that 1 priority access population before it goes into effect to make sure that we're not going to get more hiccups with it.
Director, go ahead.
Mr. Chairman, thank you. If I can just add, since 2021, spring and summer of 2021, these recommendations or options that you see in front of you are not Department of Health generated in a vacuum. So, for about 3 years under Franz's leadership in the behavioral health divisions, most of, if not all of these options and recommendations come from a large stakeholder group, not just the department, certainly facilitated by the department, where the providers have voiced their input, have even voted in some cases on what we should be recommending. So I'm confident, sitting in front of you today saying that with the options we're recommending and the options that the Mental Health and Vulnerable Adult Task Force have drafted for your consideration as legislation for this, have been pretty much universally agreed to through not only the task force, but since 2021, the committees and subcommittees we've set up with the provider and stakeholder groups, just to make sure, as Representative Yin mentioned, this is $100 million system with a lot of providers and a lot of clients. So it is quite complex, as you know, and we wanted to make sure that when we implement on July 1st, 2024, we don't inadvertently instill some system shock into what is quite a large and complicated system. I'm very thankful to the provider group for working with us for the past 2 or 3 years on these really complex issues and these policy decisions, where I think in most cases we've struck a balance where the benefit to the state, the benefit to the providers, but ultimately the benefit to the folks that they're serving and will be serving, that we're striking that right balance. So I just wanted to point out, Mr. Chairman, that these are not things we've noticed in the past 2 or 3 weeks and said, oh, we've got to get this changed in statute. This is a pretty long vetted process with the provider and stakeholder group to get to these recommendations.
And I would add to that, if there was a way you could magically go back and watch all those meetings of the stakeholder groups, it's some pretty intense meetings with a lot of good debate. And these were come to after a lot of intense debate. And then the mental health task force, we got that product and we've come with what's before you today. I don't think it's the end all product. I think you'll still see some adjustments as we move forward after 2024. But right now, I think we've got a good product that we're moving ahead with to get this thing working the way we want it to work to start with. So with that said, any further questions, committee? Go ahead, Representative.
Thank you, Mr. Chairman. A couple of questions. So, and maybe you've covered this and I missed it, but we're talking about people above 200% of the federal poverty level. Do you have a number for what that household income is?
Go ahead, Rick. Franz,
Mr.
whoever wants to take it.
Chairman, Representative Hornock. So the poverty level is about $11,000, 100%, if I recall correctly, for an individual. So it depends of how many people are in the household. So it's not just one number, right? So, but if for a single individual, it'd be about $21,000 to $25,000, I believe, and it's below 200% of the poverty level is those who are eligible.
Follow up.
Yes, thank you, Mr. Chairman. Do we know, is there information that you have that tells us how many people within Wyoming fall into this category?
Mr. Mr. Chairman, Representative Hornock, it's a really good question. The unfortunate answer is because we've operated the system on a sort of this block grant basis, the clients, we don't have really granular, very good income information on them. So a big part of this process is basically taking everybody who's currently receiving services and screening them through the existing Medicaid system. And that will determine a very accurate income based on connections with like IRS workforce services data. And so we will have much more information once this eligibility screening process is complete. But right now, I couldn't tell you the distribution of those clients. We just don't have we have never really had a system that could collect that kind of information on these behavioral health clients.
Very good follow-up.
Thank you, Mr. Chairman. Yeah. Just thinking about what could possibly happen with this, I'm wondering if taking away this clause kind of incentivizes insurance companies to pretty much not cover health insurance because they already know that people within this income bracket will be covered already. How do we prevent insurance companies from just taking away that insurance, knowing that the state now is just going to provide that because now the state will, and these people will be covered at that point in time, which, the coverage is covering mental health is, a decent thing to look at. But it seems to me like this kind of incentivizes the insurance companies just not to touch this at all. How do we prevent that?
Mr. Chairman, Representative Hornock, two answers. One is these people are already covered now. So we are already paying for anybody in this state to receive behavioral health services, right? So what the behavioral health redesign does is actually neck down the eligibility at the very, these high priority populations. So that incentive would exist now because those services are already covered. The second answer is insurance companies, particularly the ones that are regulated on the exchange, like Obamacare exchanges, are required. There are federal mental health parity requirements. So they are required by law to provide mental health benefits in theory to the same extent as physical health. So for those two reasons, I don't think there is an incentive. This would change the incentives at all.
Director.
Mr. Chairman, Representative Hornock, if I can add, again, what you see in the recommendation here that we're affectionately referring to as punt and study, we will start the process of getting to a point in a system that does exactly what you're talking about. And we do it in other systems that are mostly Medicaid run. But I'll give an example. Years ago, we changed the way we pay for Title 25 commitment services, where previously a designated hospital or provider would send a paper bill to the Wyoming State Hospital, who then we'd have folks at the state hospital that would review the bill, the claim, and make adjustments handwritten to say, well, I think we don't cover this and we need to use a Medicaid rate here. Years ago, we put all eligibility, small system, small number of clients, but we put all eligibility and payment of Title 25 through the Medicaid technology system, not necessarily just for Medicaid clients, but we had the technology. We can design eligibility and benefit plans to be beneficial to the state, even outside of Medicaid. By nature of that, what we can do now when we get bills from providers in Title 25 is determine, is this client just a full state general fund client, or were there what we call third-party liabilities or insurances that are there and do cover or could cover these services? And it's actually a benefit to the state, as you can imagine, financially, because we can now identify that liability elsewhere and reduce the state costs. In a strange way, but also a good way, it's a benefit to the providers because folks in this type of condition come in on an emergency basis, might not be of sound mind at the time. And so if you ask a client, do you have your insurance card? Are you insured? You often don't know. And so some of our providers, it's a benefit to them because we identify, hey, there's a primary payer here before the county or the state begins picking up the bill. Let's recoup that payment from the private insurance company. So that's working in Title 25. I'm not saying it's working perfectly. It's always variable, but we're setting ourselves up here to do a very similar concept in behavioral health redesign. What we're proposing now, just because of some of those unknowns, as you were asking, the numbers of people in the current system who might, have third-party liability or have insurance, we just don't know. But starting this winter and spring, we will begin running all of the clients like we did in Title 25 and like we do now through a centralized eligibility rules-based system that technically has the capabilities to identify those third-party liabilities, those insurance coverages. And what we don't want to do, but as Franz mentioned, we're ready to execute as the statute is written now on July 1st. What we don't want to do is put inadvertent barriers to treatment for high priority clients by nature of saying, if you have any private insurance at all, you're not eligible. I think that could hurt us potentially with some clients that wouldn't be able to receive services because of lack of compensation, where in this recommendation, everybody gets run through the eligibility system. We monitor the claims volume, we monitor third-party liability. And in 2024, we engage with you all and any other committee that works on this to say, here's what we're seeing month after month. And now we can take a scalpel instead of the sledgehammer and say, here's the eligibility and third-party liability process that we think long-term should be in the system. But I think, and we think it's beneficial to give it a year to see what that population and what that potential savings or claims volume looks like that could be on the private side.
Mr. Co-Chair.
Thanks. Just a question. If a person is Title 25 and voluntarily committed against their will and they have private insurance, can you bill their private insurance for an involuntary commitment and thereby, you know, force them to pay out of their copay deductible, increase their insurance rates, even though they're being committed against their will?
Mr. Chairman, that is a really good and very deep question that I deal with a lot. And the answer in general is yes, but with a lot of limitations and some significant policy decisions, even on the ethical side of what should a provider be doing. So as you know, the way it works in statute is for a Title 25 commitment, there's county responsibility in the first 72 hours, and then there's state responsibility for payment in after 72 hours of commitment. Statute dictates that before any provider, i.e. a hospital, bills the county or the state for Title 25 services, that they recoup all payment from private or public insurance. And there are insurance plans and Medicaid that will cover those, some or all of those services. And so that happens. Your question is a good one, because in private insurance, most folks have co-insurance, copays, or deductibles. So the question comes up often. Someone is involuntarily detained against their will. Should they have to be liable for their copays, their co-insurance, and deductibles? Where our policy stands as a department is that is legally permissible for a provider to bill that and levy copays, co-insurance, and deductibles, but should be done with the client's best interest in mind. It's not dissimilar from if you get hit by a bus, it's not your fault, but you get taken to the hospital or the emergency room. Typically, your insurance plan, your contract with your insurance company, and that contract between the insurance company and the provider, it is what's on record, and that's usually what is used. So get hit by a bus, your copay and deductibles are, unfortunately for those who have been hit by buses, levied. And it is an interesting question, but right now that's how we implement that policy.
Follow up, Mr. Co-Chair.
Follow up in those first 72 hours, are counties allowed to do the same thing?
Mr. Chairman, yes, I will say that our partners in the counties, luckily for them, are not giant health departments. So they're typically not and shouldn't be, healthcare billing and claims adjudication entities. So, but in theory, presumably, yes, the same rules are operating. But keep in mind, it starts on the provider side, because the provider has a Title 25 client, and then during or after the episode or the stay is now seeking reimbursement from either county government, state government, or public or private insurance.
Very good. Further questions, committee? Go ahead, Representative.
Thank you, Mr. Chairman. So to put it simply, option B, that removes the public or private health insurance language, effectively expands what the state will be responsible for paying for. Is that correct?
Mr. Fuchs.
Mr. Chairman, Representative Ward. So the fiscal impact of the state is actually minimal. In this whole model, we are capping how much the providers can bill on the general fund basis. So the budget is not at risk. Our biennial budget of $100 million of general fund is essentially capped. So if we are paying those bills and the insurance is not, say, under the status quo, right? Then providers can draw down up to their cap with that as they bill. And so whether it's that particular bill or some other bill that they incur or that they submit, at the end of the day, they will likely reach that cap. But the exposure to the state is the same.
Follow.
Thank you, Mr. Chairman. But it expands what the coverage that the state is responsible for paying for, because otherwise it would fall on private insurance, correct?
Mr. Fuchs.
Mr. Chairman, Representative Ward, I think so the frame of reference kind of to Representative Penn's question, are you looking at the current status quo? The current status quo, right, we pay these block grants. And so we are still paying that role doesn't change. It actually shrinks. If you're looking at the perspective of the bill itself and changing from what's going to be implemented on July 1st, 2024 to what will be changed, then yes, it does expand the populations that are covered by the state. Absolutely.
Further questions? Representative.
Thank you, Mr. Chairman. So by September of 2025, we'll know which system works best because you're going to track the numbers, you're going to track the money. Because right now we're still working in the blind, paying 100 million biennium. This is going to tell us if it's working or not, and if we're keeping recidivism low or non-existent by taking care of those people right off the bat, right? So this is a win-win theoretically, because we don't know where we are right now.
Mr. Chairman, Representative O'Hearn, yes, we will know, what we will have for you in September 2024 is an early indication of the volume of third-party liability that's out there. Not that we've avoided, but that we've tracked in the system, right? So we'll be able to say, okay, here's how much we project we could recover from insurers. And then we could also have a cost estimate for building the option B machinery. And we could say, okay, which one is bigger, right? If there's only a handful of people that are insured and the recoveries are small, but it costs multi-millions to build this new infrastructure, option A is probably preferable, the cost avoidance, right? So that's the kind of information you all can expect on this topic, but we will also have initial outcomes data from the outcome side of the house on, people being housed, employed, engaged in treatment, and how successful that is going, at least initially for the first few months.
Further questions, committee? Senator.
Thank you, Mr. Chair. More questions, more thoughts, and I'm hearing one thing and then I'm hearing something else. Still concerned about the qualifier that we want to remove. It seems to me if we remove that, we are going to get more people joining in, and we really don't want more people joining in. So I'm just still concerned about why not just leave it and punt and study.
Mr. Chairman, Senator Hutchings, I think, from our perspective, we think that there are people receiving services now that would not receive services if the current statute goes into effect. And that's just a concern that we're raising. I think it's obviously, this is a choice we're bringing to you as the electeds to make that decision.
Yeah.
And I think whether you modify this bill or do not introduce it, whatever happens to this bill, we are prepared to execute the law as written.
Right.
So we just want to make sure that you all know the consequences and what will happen either way we go.
Mr. Kocher.
Yeah, just real quickly, I think part of the issue, Senator, is this population. I mean, they're in and out of mental health centers, out of the county jail, out of the state hospital. They're generally not the same population that are holding jobs they're not holding long-term stable jobs. They have too many behavioral health episodes, and until they become stable, they're not really allowed to work in the workplace for any lengthy period of time or be hired at higher level paying jobs. And so instead of there being these kind of catches and certain insurance clauses about, if mental health or substance abuse are covered, we just say 200% of the poverty level. I would think I don't know if we don't really study, but kind of anecdotally of the patient population we continue to see who are in this high group, they're not being able to hold down a job as it is. So the 200% of the poverty level kind of covers 95% of what we're seeing now.
Mr. Chairman.
Yeah, go ahead, Rick.
If I can add one thing to Co-Chairman Swanenster's point and Senator Hutchings to maybe elaborate on your questions a little bit. The vast majority of folks that we do see in these priority populations, at least initially, will likely be below that poverty threshold, just by nature of their social circumstances. The goal in the outcome side is to change that, obviously, and we want to implement a system that not only provides care and coverage and reimbursement for their behavioral health and substance use services, but also incentivizes providers to work with them on those social outcomes. The second thing I'd like to mention, because I know we speak fast and I apologize for that, but we blend a lot of terms we're talking about leveraging Medicaid technology in this general fund system, which is absolutely true. Excuse me. But we are not talking about Medicaid as, you know, this redesign. There's overlaps, there's technology, there's populations that would qualify for both the general fund plan and their Medicaid coverage. But to the point about what's the risk, is financial risk or exposure for the state, this does not operate like Medicaid in that, as you all know, if folks enroll in Medicaid, you're eligible for Medicaid, and the budget is subject to the volume of clients we have and their utilization. As Franz mentioned before, this is a general fund program the state completely controls. So even in the unlikely event, in my view, that we see thousands and thousands and thousands of more people come onto the rolls or be eligible for this program, which I think is highly unlikely since the reform is shrinking the population by prioritizing. The budget is still the budget that you all set. So we cannot exceed that. There's not an entitlement program on the back end of this that says, oh, well, we've seen thousands of more clients. Now we have to pay for those services, if that makes sense. This is a state general fund, state controlled system.
Representative Penn.
Thank you, Mr. Chairman. So I'm just trying to make sure that I understand the two bills that we have. There's two, right? So we have before us. These are your requests to amend what was set prior to allow you to study what you hope to study to find out if we can fix this and do it in a more economic way. And so that original bill that we're amending, is there a sunset on that? Does that end? Like once our study is done, we say, okay, these are results. Now we need to draft legislation to say we're going to put this into place for good, or is that automatically just go and it's a thing?
Director.
Mr. Chairman, Representative Penn, I think obviously you all in any session would reserve the right to change all of this legislatively. I can't remember on the original behavioral health redesign, I think it was House Bill 38, if there was a sunset. I know it was debated. If there is, it's out in 2026 so that we would report back and the committee could study if it's worth keeping going. But again, what the mental health and vulnerable adult task force proposed, which we sat on that task force and happened to agree with the legislation that's before you today. The bill that they proposed does change that original statute that was promulgated in 2021 for that eligibility piece of the lowest tier. But I believe the change that you saw highlighted in red on slide 14 would be session law. Is that correct, Franz? Or is that statute change? Okay, the session law would be on the third party liability option. Representative Penn, I apologize. The 351613 on slide 14, striking that private or public health insurance clause would be an amendment to the statute that was proposed or that was legislated in 2021 that takes effect July 1st of next year.
Okay, further questions? Senator Hutchins.
Chair, going back to 14, what's in the red? If we take that portion out, what's to say someone who just shiftless, lazy, doesn't want to work, or their household income is not more than 1,000% of the federal poverty level, can they jump in on this? Can they be considered indigent?
So, Mr. Chairman, Senator Hutchings, just to make sure I'm understanding your question, you're asking if say somebody is above 1,000% of the poverty. Okay. If somebody's under 200% of poverty level but is not working, yes, they would qualify under this language. there's no work requirement in this, so.
Further questions, committee? And Mr. Co-Chair.
But they do have to be diagnosed with a behavioral health or have an entry into the system where they've either been incarcerated or this isn't just someone seeking mental health services. This is somebody who's had some kind of event, either a Title 25, an incarceration, being sent to the state hospital. This isn't just anybody off the street. This is a couple of steps down the line after they've gone through an event, correct?
Mr. Chairman, those would be the higher tiers. So the acute adults with severe mental illness, obviously coming out of the state hospital, people coming out of corrections, those are all higher tiers. This tier is the very bottom tier. It's the tier 3, and it is a catch-all. So anybody who is under 200% would qualify.
Okay, further questions, Representative?
Thank you, Mr. Chairman. So we do have a mental health problem in many places. It's probably here in Wyoming more than we want to speak about, but I'm curious, give me an idea of what services are covered under this, because we're talking about people that fall within this category. I can see that just about everybody in the state hospital falls in this category because nobody's going out working. Just about everybody in the county jails falls into this category because nobody's going out working. Private psychiatrists who come in, or who bring people in, witch doctors, or who knows what. So what services are we talking about with this? I know that we have issues. These are probably populations of people that we need to do something for, but I'm a little concerned that this $100 million is just going to our state hospital. It's just going to our county jails. It's just going to that kind of service when we're serving those people. We're almost double dipping potentially with those type of people, where we're already providing service to them and then we're billing ourselves back for the services being provided in some way. I don't know if that's true at all, but just curious on the specific services that we're dealing with here.
Front.
Mr. Chairman, Representative Hornock. So 2 points. One is the $100 million of biennium only goes to community mental health centers. So it wouldn't go directly to jails or the state hospital. Those are all separate, of course, other large budget items that are outside of the system. So the $100 million is specifically to those community mental health centers. What they currently provide is a mix of outpatient and residential behavioral health services. So that includes mental health and substance use disorder treatment, both on the outpatient and residential side. So that's going to be things like individual therapy, medication management, socialization, obviously the residential treatment, right, on at varying levels of treatment, from crisis stabilization at the very tippy top to sort of supported living environments at the bottom. It's a pretty wide spectrum of mental health and behavioral substance use disorder services. That's not going to change under this redesign. I think what's changing is going to be the outcomes payments. Those dollars are going to be much more flexible. And so providers will be empowered to use those dollars. At the end of the day, they're going to be incentivized to get people engaged in their treatment, get people employed, get people housed, and they can use those dollars more flexibly. So there may be a variety of other ancillary services that happen that aren't specifically prescribed by the state. But the base menu of services won't change, if that makes sense. I hope did that answer your question?
Mr. Co-Chair.
And ultimately, even the high expense is still cheaper than putting them and housing them in our prisons, our county jails, or the state hospital. And so even though it's still a little more expensive and we're paying the community health centers more, getting them out of our state institutions saves us money. And it's the ultimate goal, correct?
Mr. Chairman, correct.
High level.
I will say, though, that the budget is actually staying the same, right? So we're not actually paying the centers more. We're necking down the population they'll serve and prioritizing the dollars.
Okay. Okay, I don't see any more questions. Continue. Yep. Can you tell us about the second bill?
Mr. Chairman, this second bill actually came out of the Mental Health Vulnerable Adult Task Force, specifically focusing on the definition of vulnerable adults. And what it does is it adds, you can see the main effect is on the second page. It adds adults with severe mental illness shall include vulnerable adults as defined in Title 35-20-102A. And that's a DFS, I believe a DFS reference to vulnerable adults. And so, Mr. Chairman, I think what this really does, it doesn't change things too much because those folks would already have met those criteria. If you read the criteria for adults with severe mental illness, they're going to have a vulnerable adult has a substantial probability of being unable to meet their needs for food, shelter, and medical care. That's generally speaking, but there is going to be some areas where vulnerable adults may not be covered. For example, dementia is not considered a mental illness. So someone who may have the same criteria and the same behaviors and the same risks as a vulnerable adult may not fall under the severe mental illness definition because that's specific to mental illness. But it's just really just one's a physical brain disease and one is a mental illness, and there's a distinction there. So I think that's the main effect of the bill, but I defer to the director any further comment.
Director.
Very briefly, Mr. Chairman, the bill 24 LSO 174, as Franz mentioned, came out of the Mental Health and Vulnerable Adult Task Force in a completely separate topic from behavioral health redesign. It was really in the discussion about the legal ramifications and the statutes that the state has had on the books for years, decades, of what constitutes a vulnerable adult. Generally elderly folks who are at risk of financial exploitation, et cetera. So there was a long discussion about that service continuum that largely operates out of the Department of Family Services, of how folks are deemed to be vulnerable adults. It was a recommendation from the task force that because of now bringing in the separate issue of behavioral health redesign, that we as a department are working through this comprehensive reform to this system, that the vulnerable adult reference should be added to the definition of adults with severe mental illness in the behavioral health redesign, because it really does mesh well together. You can see, as Franz mentioned, if you go reference 35-20-102, which is the current definition of a vulnerable adult in the Department of Family Services kind of legal framework, it matches very closely to who we would be serving in behavioral health redesign and with adults with severe mental illness. So it references it here that they would be part of that eligibility tier. Again, extremely low volume and populations that would likely, even without this reference, have been eligible anyways. But I think it's a good thing to reference it in the event that a community, a county attorney, whomever is dealing with a vulnerable adult case, looking for a service providing entity that can help that person, that we wouldn't exclude them from eligibility in the community mental health center if that type of service could be effective. So that's really a simple bill, one page and one small change, tweaking the definition within behavioral health redesign.
Very good. Questions, committee? Go ahead, Representative Ward.
Thank you, Mr. Chairman. So essentially, it expands adults with severe mental illness to include vulnerable adults who may or may not have mental illness. So again, it's expanding the number of people covered by this definition, changing the definition of mental illness to include vulnerable adults, which could be people who don't have mental illness, correct?
Mr. Chairman, Representative Ward, correct, that this recommendation from the task force would expand that criteria slightly.
Franz, go ahead.
Mr. Chairman, if I could just add, just for the committee's edification, the vulnerable adult definition in 35-20 is any person 18 years of age or older who is unable to manage and take care of himself or his money, assets, or property without assistance as a result of advanced age or physical or mental disability.
Further questions, committee? Seeing none. Let's go ahead if we can. Let's move on and get some public comment on both these bills and these topics, if we could. Thank you very much. Okay, now's your chance. Ms. Somerville, welcome.
Morning, Mr. Chairman, members of the committee. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers. And Mr. Chairman, my comments are pretty short. I think the Department of Health has covered pretty much everything. We continue to work with them on a pretty much a weekly basis, trying to move forward this redesign project. It is definitely intense and a lot of work, and there's a lot of nuts and bolts to move around to ensure that we do this well, both for the state, the providers, but most importantly, the people that we're trying to help and get them moving forward. So on the first bill draft, the 24 LSO 116, that was substantial discussion with the community mental health centers on how we move this forward with, frankly, the least disruption while we move through studying exactly what all of those populations are going to look like, the numbers, everything that was described by the Department of Health. What is important to us is, again, making sure that we can keep our providers open and stable and open to those clients that need help. And we think that this change will help provide that stability while we continue to work on some of the finer details and come back. In some of the questions that were asked earlier, there is a report back date on the original legislation to this committee of September 1st, 2027. Is that it has to come back to the Labor Health Committee for another full report, as well as I think we'll be back again in 25 as well. So I think that there'll be several opportunities to come and discuss and check in with the committee and make additional corrections. I also want to say from the outset of doing a project like this, I think one of the things that I've had to work really hard to keep in mind and working with my centers to keep in mind is this is a massive shift. And we knew that we were going to try to do it right the first time, but we knew that we would potentially need changes along the way. And we've continued to work on those changes, and we hope that you'll support this piece of legislation moving to the legislature for further discussion as part of one of those changes to try to make this process better. I know there were a lot of questions about services and insurance parity, and I just want to add the comment that in terms of insurance parity and the potential of insurance companies maybe backing out on what they pay for, there is federal legislation as was described requiring mental health and substance abuse treatment parity. There's also Wyoming, a bill that was passed in Wyoming in 2019 mandating compliance with that as well. As providers, we do try to monitor that and keep on top of that and address issues when it comes up and it's affecting client care. And we will continue to do that. And Mr. Chairman, with that, I'd be happy to stand for any questions on either of the bills.
Very good. Questions? Go ahead, Representative Chin.
Thank you, Mr. Chairman. Ms. Somerville, so I voted against House Bill 38 because I thought it was going to reduce the population that we serve. Do you have an estimate, even if we pass these fixes, of how much of a population will no longer be served by the block grant that we previously had before?
Ms. Somerville.
Mr. Chairman, Representative Yin, so I don't have a specific population estimate for you. I will tell you in general that it's going to that 200% of the poverty line cutoff, that is less than what a lot of the community mental health centers run right now. Some of them run it up to 250 or 300. So we are going to lose some folks. We do not have good enough data to be able to calculate that number. So again, hopefully we'll be able to answer that question better in a year.
So, Mr. Chairman,
Go ahead, follow up.
just to confirm, in 2024, when this goes into effect, we are going to be shrinking the population that's being served.
Ms. Somerville.
Mr. Chairman, Representative Yin, yes, we will be shrinking the population that's served.
Go ahead, Representative.
As far as shrinking the population, that's in tier 1 and tier 2, because from my understanding, tier 3 is expanding, correct?
Go ahead.
Mr. Chairman, Representative Trujillo. So actually, it's kind of the opposite. So the categories in tier 1 and tier 2 that are called out specifically, those folks are right now. Let me back up. Right now, today, the system is completely based on financial qualification. So if you're at whatever the sliding scale, under the sliding scale fee, you're at 250% or less of the poverty level, and you walk in the door, it doesn't matter what your diagnosis is, it doesn't matter what your designation is. Doesn't matter if you're incarcerated or part of the DFS system, or you just walk in and need general help for depression or something like that. It doesn't matter. Your service eligibility is based on your financial qualification. This changes that. So the top two categories will now be, you have to have that categorical designation, right? You have to be criminally justice involved or one of those other pieces needing mental health and substance abuse treatment to qualify. But then tier 3 is what I would casually call the remnants of the old system. So category 3 is that general access piece now, but we've lowered it to 200% of the poverty level, if that makes sense.
Yeah, further questions, committee?
Mr. Chairman.
Go ahead, Senator Doxer.
Two follow-ups, Mr. Chairman, Ms. Somerville. Used the phrase massive shift. Would you narrow that down a little bit? I was not privy to all the subcommittee's work I need to understand what you're saying with that. And then Representative Yin's asking, it shrinks the population. How much? What's the number? Thank you. Those two questions.
Ms. Somerville, may be useful when you answer that to go back to, and Senator Doxer will understand some of this, is that what we used to do, let's just say pre-behavioral health system, whatever, because this is a massive shift that's already happened. And go ahead.
Mr. Chairman and Senator Doxter, I'm going to try to answer those questions and keep me on the road here. So in terms of numbers, I'd be happy to get you, Senator, reports of the numbers that we serve now. What we cannot tell you is what those number estimates are going to look like for the next year or two. We don't capture that data right now in our systems. In terms of the massive shift piece, and maybe I'll color that comment a little bit with just maybe the number of hours we've been spending in meetings trying to work out all the nuts and bolts. In the past, the community mental health system is a block grant system. That's how it started out originally in Wyoming, where it was, here's the grant, keep the doors open, see people, serve people. Starting about early 2000s, there were some conversations and changes that started to tune that system just a little bit. It was still block grant based. And for the most part, that's basically how it's remained. We put some performance compliance metrics in the contracts for the centers in the last 5-6 years, but basically it's block grant based. What we're shifting this to is essentially it's a fee for service. So there's a component that's still grant based to, especially to in our rural centers, try to make sure we keep the doors open, the lights on, all of those things. But we're changing these community mental health centers to be more performance based, both in a fee for service payment, more like you get at go into a regular doctor's office for a checkup where you send in a bill and you get paid, but also in terms of outcomes and following those health outcomes through the clients. That's a really, really big shift to a system that's been statically unchanged for more than 40 years.
Go ahead, Mr. Kocher.
Would you agree we're paying for effectiveness? So instead of just sending everybody money and hoping things get better, we actually, I would almost call it a pay for performance, that the people who are improving and are stable and are not, going back into higher levels of incarceration or back to the state hospital, we're willing to give more money to, and this is it's the same people. I mean, we find coming in and out of our community mental health center, they go up the chain, they go to the state hospital or get incarcerated, they come back for 6 months, they get rearrested, right? And so we're actually trying to give more money if we are effective at having this population, breaking the cycle. Instead of just saying, hey, here's some money and solve it, we are trying to be very kind of corporate in a way, saying we will pay you if you can make sure you're giving us positive outcomes. And so there's this pay for performance, bonus, whatever you want to call it, to actually prove that we're being effective. And that's because right now we're just spending $100 million. We're not sure if we're actually doing anything, because it sure seems anecdotally like the same people are just moving around for 20 years until they have an end of life event and they cost a lot of money. So we're really trying this kind of innovative approach to save us money, pay for performance in a weird social, in health, right? You don't really, it's not like corporate America, but we are trying to do an innovative system that actually has positive outcomes that reduces state general fund dollars.
Go ahead.
Mr. Chairman, Mr. Co-Chairman, that is correct in every way. We are really trying to move to a system that pays attention, I think, to not just providing the care for the clients, but making sure we're doing it in a way that's productive long-term. So when they talk about that outcomes-based piece, while it's a completely new idea, I think we might be one of the first, if not the first in the country to try something like this out. What it really says to the providers is, how can you think differently about taking care of that client? So that client that maybe has been back in the past and they've never been able to get them out of their house. They've maybe never been able to get them involved in their community. What can that provider do differently to take that, next half step to get them a 2-hour volunteer gig the first month that they're with the community mental health center, and start to baby step them into living more within the community that might ultimately end up helping them be more stable. And that's through education, employment, volunteer work, community involvement. Those pieces, those social determinants of health, that's what we've been asked to do in this legislation. And I think it's worth a shot. I think that's what all of the meetings over the last 3 years have been, is that this is worthy of maybe doing it. This might help us do it a little bit better.
Editorial comment is that this is something that governments, in my humble opinion, should do more of. We throw money at an awful lot of things. And in this case, it's something we've been throwing money at for years and years and years. And we don't know if it works or not. We think it does. Anecdotally, it works, right? I trust our behavioral health people, our treaters, our providers. And we're just saying, let's see what we're really doing. Let's make sure that what we're throwing the money at works and we're doing the right thing. So I wish government would do more of this instead of just throwing money. Further comments? That was my editorial. Go ahead, Representative Penn.
Thank you, Mr. Chairman. So it seems to me like our mental health providers are probably already trying to do a lot of these things as far as get people in the communities. I mean, it's understood that that's the end goal, is to not have the recidivism and rehab those things. And so if those attempts are already being made and we're seeing the results that we're seeing, how do you anticipate this bill is going to change that? I mean, you can't try harder if you're already trying your best. So how do you anticipate this affecting that?
Mr. Chairman, Representative Penn, that's a really good question. And when we spent a lot of time talking about when we first started this as well, we think, we're doing all of this. What else can we possibly do? And I think what really happened with the process is we kind of threw out everything we knew about how it's supposed to work. We spent a lot of time researching and consulting with people that do different types of programming, different types of evidence-based practices, and really tried to say, all right, well, here's the box. Anything that's in the box is off limits. What are we not doing? And it's really opened some doors to some interesting conversations with new organizations that have never been at the table, that we think might be helpful in terms of transitioning clients out of care back into the community, opening up new doors on how do we get people better connected into housing services? How do we work better with employers and looking at new programs? And then maybe one of the biggest pieces is, how do the community mental health centers themselves, because they're all independent agencies. They're not one agency. They're all private nonprofits. And how do they work together as a team better across the state? So I think in just those two veins, that's where we've seen a lot of the potential to move this forward. And to the point about, I don't know that in terms of the community mental health centers, getting an extra added incentive payment will really make the difference on whether you do that or not. Because once a program's set up at a community mental health center, they're going to run it like that. But I think for the state's peace of mind, they want to be able to measure the effectiveness. They want to be able to track that data. They want to be able to see, okay, we did X, Y, and Z. Did it produce this outcome or this outcome? Did it cost us more money? Did they go back to the state hospital? Or is that person working 20 hours a week now at a job for 3 months? And allow the state to really take a look at the investment and make sure that the money is being spent well.
Follow up, Representative Penn.
Thank you, Mr. Chairman. Changing gears, you mentioned earlier a 2019 bill that would mandate compliance to an act or something. Would you be able to help me find what that bill is?
Ms. Somerville.
Mr. Chairman, Representative Penn. So the federal legislation is the 2008 Mental Health Parity and Addictions Equity Act. And the Wyoming legislation was House Bill 11, Enrolled Act 89 in 2019. And that bill's very short. It's one paragraph. It just says in the state of Wyoming, people shall comply, insurance companies shall comply with the 2008 federal legislation. And I'd be happy to send you copies of both of those.
Okay, further questions, committee? See none. Thank you very much, Ms.
Thank you.
Somerville. Further public comments? Now is your opportunity to come up front. Yeah. Welcome, Tom.
Well, thank you, Mr. Chairman, committee. My name is Tom Laycock. I'm Associate State Director for AARP Wyoming. Speaking specifically on the second bill, the moving vulnerable adults into tier 3, wanted to offer our support and offer an attaboy to the Mental Health and Vulnerable Adult Task Force. I think we're 3 meetings through, with the fourth coming next Thursday. So it's been a fantastic conversation. For us, we appreciate the fact that the Department of Health did mention that a lot of these folks would already be covered, although this makes it probably a little more concrete that this is a tool for those who need it, who unfortunately can't help themselves. So we were very appreciative of that. Mental health for older adults, and obviously not every vulnerable adult is an older adult. Not every older adult is a vulnerable adult. But we do see a number of them that are. We know that 1 in 5 over the age of 65 actually have a mental health condition that could be benefited through mental health care. We also know this is Suicide Prevention Month, and unfortunately, Department of Health data tells us that the highest occurrence of suicide comes in the age bands of age 70 and over, and really has a bump after age 80. So for those reasons, we're supportive. We appreciate what the task force is doing, and would urge your support. Thank you.
Questions from Mr. Laycock? And I would add to that conversation that Wyoming now Department of Health should have shared this, but I'll do their job for them, is that we're no longer number 1 in suicide. Right now, we're number 3. So that's important to know. We're not where we want to be, but that's an improvement. No further questions from Mr. Laycock. Thank you very much. Further public comment? Going once? Going? Gone. Do we have anybody online for public comments? It's early. They're not awake yet. Okay. Okay, committee, my proposal is that we're closing the public comment. We have 2 bills before us. Let's do them one at a time. If someone would like to move, you choose whichever bill you want to move first. We'll work through both of them, amend as necessary, and vote and get these 2 bills taken care of. Would anybody like to move either one of these bills? Representative Chen.
Mr. Chairman, I'll move the first one, 24 LSO 0174, working draft 0.5.
Okay, we have a first and a second. Committee comments, suggestions, amendments. Representative Penn.
Thank you, Mr. Chairman. I would like to offer an amendment to add a sunset of 1 year to this.
We have a first and a second. Committee comments, discussion. Mr. Co-Chair is running forward. I think that means he has something to say.
Oh.
Mr. Co-Chair.
Thank you, Mr. Chairman. I just would ask if it'd be friendly to make it 2 years just to fit along with the budget cycle. Because that would, I mean, if we are going to put a sunset, it'd be nice to make it the next biennium, because we're living a 2-year biennium cycle, if that would be agreeable.
Would that be a friendly amendment?
Yeah.
Would that be okay with the second? Second friendly, okay. Further comments, committee? Go ahead, Representative Chen.
Mr. Chairman, the only awkward thing is that we're going to have this report in 2027. So it's going to be, I guess we'll have the report with sometime before the sunset and sometime after the sunset. I don't know if that's something that we want but we're not going to find out what the result is unless we get an earlier report before the sunset of what this change makes. That was a very roundabout way of saying this is going to be very awkward, and probably we'll have a second report rather than the one already required in statute for 2027.
That was an awkward comment on an awkward amendment. Very good. Comments, committee, on that comment? I believe it's some week more around. Representative Penn, go ahead.
I just think that it, it gives us some time to study it, like we said, maybe both ways and get a better idea, because obviously we want to be most economical. We want to be serving the population that we can. But I don't think this is something that we want to just automatically set. If it's working, then we can easily continue that at a later date.
And I would add to the committee, this is not something that you're going to see the end of in 1 year, 2 years, 3 years. This is one of those things, much like Title 25. We're going to have reports many, many times down the road for those of us who are reelected and continue to want to be tortured and be reelected. So I think we're going to hear report after report every year anyway. So with that, for no further comments, let's vote on that amendment, please. All those in favor of that amendment by Representative Penn, I say aye.
Aye.
Opposed, say no. That amendment passes. We got that amendment. LSO, you got that. Okay, very good. Further comments, amendments? Seeing none, let's do a roll call on that bill, please.
Mr. Chairman, this is roll call for 24 LSO 0174 Behavioral Health Redesign, Vulnerable Adults as amended. Senator Barlow,
Excused?
Senator Bouchard,
Excused?
Senator Dockstetter, Senator Hutchings.
No.
Representative Chadwick.
Aye.
Representative Klauston,
Aye.
Representative Hornock,
No.
Representative O'Hearn,
Aye.
Representative Penn,
No.
Representative Trujillo,
Aye.
Representative Ward,
No.
Representative Yin,
Aye.
Co-Chairman Wanitzer.
Aye.
Chairman Baldwin.
Aye.
Eight aye, 4 no, 2 excused.
Okay, that bill will proceed forth to session. Committee, that leaves us with 116 behavioral health redesign amendments. Would anyone like to move that bill ahead? Moved by Representative Chadwick, second by Representative O'Hearn. Discussion on the bill, committee. Go ahead, Representative Ward.
Thank you, Mr. Chairman. As you could probably guess from my question, I'm not in favor of this. It expands coverage beyond the original intention of the bill that was passed. So I will be a no.
Further discussion, committee. Representative Penn.
I'd like to offer an amendment on this bill as well, same as before, sunset for 2 years.
Second on that amendment?
Second.
Second. We have a first and a second. Discussion, Mr. Co-Chair.
Thanks, Mr. Chairman. So the only change, right, is this page 2, when we're taking out private coverage for mental illness or substance use disorder treatment. And I guess I'm just not sure why that would be sunsetted. That means it would come, I guess my question is this on the whole behavioral health redesign that we're sunsetting, or just this amendment change? Maybe some more clarity before I offer comment.
Representative Penn.
My intent would be to sunset the change, to then again, giving us an opportunity to see maybe both ways, if there's a significant difference in the amount, the cost to the state with one definition versus the other.
Go ahead, Mr. Co-Chair.
Thanks, Mr. Chairman. We already have a recommendation that's due to this committee, no later than September 1st, 2025. And I would assume based on that recommendation in 2026, some legislation would be offered, to wherever we are in the process. So I'm not sure a separate sunset for 2 years. I mean, it would kind of align, but I'm not sure if it's necessary if we're already going to get a report and continue to study it. So
I guess I would agree with that, Mr. Co-Chair, is that probably in 2026, we're going to get a report on this with or without this amendment. It will be discussed and we will, it's effectively already sunset, so I don't know that this would change anything. Certainly if it's committee's desire, we can add that, but I don't know that it's necessary. Representative Penn.
I guess my question is, the report, if we leave it as is, if it doesn't have these extra qualifiers, sounds to me like that's, it would go forward in that way. It would be studied without, the part that's being stricken here. I would rather leave that in and see if that makes a difference, because so far in my understanding, we don't know, because this whole thing is a new definition. And so we don't know currently as it had originally stood, how that's going to look versus difference. And so, you know, I would still push for my amendment.
Go ahead,
Mr.
Mr.
Cook, can I have the Department of Health come back, maybe Mr. Fuchs, and as he's walking up, I guess my question is, we're fondly calling it punt end study. At what point, I guess, for statistical validity or to the conversations that have gone on, how long do you think we need a study? Can we do it in a year? Is it a 3-year? Has there been some internal conversations that after, you know, this design and people start requisitioning and then we look at long-term outcomes? I mean, it tends, in my mind, it's going to be more than a year to see if people are holding down jobs and the recidivism rate staying down. But in your mind, how many years do we need to go before we kind of make a decision on long-term?
Mr. Fuchs.
Mr. Chairman, Mr. Co-Chair, so it depends, the sunset, my understanding of the amendment is it applies only to the definition of the eligibility portion. We would have information on eligibility fairly rapidly. I think so. We're going to try to process most people from around February to July. And so within a few months, we should know the income distribution, how many people are above 200%, below 200%, and the insurance coverage. That would be available relatively quickly. Generally speaking, everything else like the third party liability would probably about a year is better. Outcomes would probably be a year, especially things like recidivism. Sometimes it takes 2 to 4 years to really notice a lot of the change there in that trend. So on those outcome sides, it would obviously take a lot longer. But specifically on the eligibility question, I think we could have the information relatively quickly.
Mr. Co-Chair.
So we already have the report due or on or before September 1st, 2025, and then we have kind of a holistic look in 2027 right now. So is there any other kind of mile marker goalposts that are currently in statute otherwhere in the design of when we're re-examining besides those two kind of indicators?
Mr. Chairman, we're not that I'm aware of in statute, but we are happy to provide any updates to the committee at any time. Please don't think we, are going to be bound by just the statute when it comes to those requests.
We would like to hear from you guys a lot. Okay, we have an amendment on the floor. Do we have any further discussion about that amendment? Seeing none. Question? Senator Hutchins.
Just for the record, I do believe I heard, and again, it could be wrong, them say that they're hoping this will work. So I think the sunset's a good idea, so we'll know that it works. Thank you.
Okay, further discussion, committee?
Mr.
Okay.
Chairman,
Go ahead, Senator Doxer.
this amendment, as with the previous amendment, brings me to the aye vote. Other than that, I couldn't. So I appreciate the consideration that we've got a catch net at the end and a review. Thank you.
Pretty good.
You put it that way.
Okay.
I guess I'll vote yes too.
Okay. All those in favor of this amendment, please say aye.
Aye.
Opposed, say no. That amendment passes. Further comments, questions? Okay, let's do a roll call on 116.
Mr. Chairman, this is roll call for 24 LSO 0116 Behavioral Health Redesign Amendments as amended. Senator Barlow,
Excused,
Senator Bouchard,
excused,
Senator Dockstetter, Senator Hutchings,
No.
Representative Chadwick. Representative Clauston,
aye.
Representative Hornock,
Aye.
Representative O'Hearn,
No.
Aye.
I'm sorry, Representative O'Hearn,
Aye.
Representative Penn,
No.
Representative Trujillo,
Aye.
Representative Ward,
No.
Representative Yin,
Aye.
Co-Chairman Swanser.
Aye.
Chairman Baldwin.
Aye.
Nine aye, 3 no, 2 excused.
That bill likewise will proceed to session. Committee, you've been work for an hour and a half. I propose a 10-minute break. I'd like to see you back here at 10:15 and we'll move on to Medicaid disenrollment.
We're ahead of, wow, that never happened.
Be back at To order. We are 7 minutes over time.
So 15 minutes ahead.
Yeah, we're ahead. We started ahead. Congratulate us. Okay, committee, we will come back to order. A comment that I forgot to make this morning. I commend all of you for meeting our formal dress code. If you've been watching our national legislators, they rescinded their dress code 2 days ago. And so we still have a dress code. We are not wearing sandals, shorts, and tank tops. Rather, we all look very appropriate, and I commend you. So, yes, and the people that are here testifying and watching as well, you're all dressed very nice, and we appreciate that. Okay, with that in mind, and with those congratulations, let's move on to the next item, item 3 on our agenda, Medicaid disenrollment, Department of Health, or designee or designees. Proceed at your own risk. Go ahead, gentlemen.
Thank you, Mr. Chairman. Again, Stefan Johansson with the Health Department, joined to my right by our state Medicaid agent and senior administrator of our Division of Healthcare Financing, Lee Grossman. And once again, Franz Fuchs, our Chief Policy and Data Analyst. Give you a brief overview and update on Medicaid unwinding, as it's known nationally. Just by way of background, during the COVID-19 public health emergency, federal policy was enacted that prevented states from state Medicaid programs from doing what we normally do, which is generally redetermining eligibility for Medicaid members on a regular basis. During the pandemic and the public health emergency, that was prohibited, and that also generated an enhanced federal match during the pandemic so that folks wouldn't have lapses. The intent was that folks wouldn't have lapses in coverage or services. And as you all know, that went on for a number of years. Earlier this year, the public health emergency at the federal level was rescinded, and that started the process, what we've been planning and preparing for a number of years. You all have heard me testify about this a couple of times, that we would anticipate the end of the federal public health emergency and therefore a kind of reinstating of prior Medicaid eligibility redetermination processes. So that started this past spring. And we're here to give you an update on what we are seeing. There's been a lot of changes over the past 6 months or so in federal policy, a little bit of goalpost moving, if I can put it that way, at certain points. But I'm pleased to say that without the addition of contract labor or relying on contract labor, Lee's staff in our eligibility unit at the Department of Health have done a really good job, not only preparing for this, but executing what's a tough thing to do, which is a lot of eligibility redeterminations, a lot of manual work to do that in order to comply with federal policy. But the balance we're really trying to strike is kind of on two sides of the same coin. One is, from my perspective, folks who are ineligible for Wyoming Medicaid by the rules that are established by you all and through Department of Health policy, we should be disenrolling those individuals so that folks who do qualify for our Medicaid programs, including our waiver programs for the very vulnerable, receive that coverage. And we have a fiduciary responsibility to make sure that the folks on the rolls of Wyoming Medicaid are appropriately on the rolls of Wyoming Medicaid. The second issue in the balance we're trying to strike is we want to do that thoughtfully. We want to prevent and mitigate, erroneous disenrollments of individuals, make sure we're doing the appropriate outreach to the folks who have been enrolled in Medicaid for the past couple of years to ensure that the eligibility standards are met. And again, if they're not, that we make those determinations and disenroll those members. The final thing I'll mention, Mr. Chairman and members of the committee, is during the public health emergency and what you'll see in our numbers today, you can really observe the spike in enrollment that we saw from 2020 through 2023 because of this federal policy where we did not do eligibility redeterminations. Other states had a very different experience than Wyoming did. With a few exceptions, we really did not see, even though we had more individuals on the rolls, an extreme increase in utilization and therefore cost. That's due to a lot of variables, but something that other states did experience. And a lot of that has to do with how those Medicaid programs are managed with what we call managed care organizations, where states are essentially paying capitation to health insurance plans on a monthly basis to cover populations. And thankfully, in this context, Wyoming is not one of those states. So we have not, for the past 3 years, been paying on a monthly basis for that enhanced enrollment. Our costs in Medicaid are purely driven by the numbers of folks we have on and their actual utilization of services, which again, en masse, we did not see a dramatic increase in utilization and therefore costs that we would have to come to you all and the Appropriations Committee to deal with as a result of the public health emergency. So with that, Mr. Chairman, happy to answer any general questions that you have as we start, but if not, I'll hand it over to Mr. Grossman to give you just a brief overview of where we are with the numbers as we do the unwinding and the eligibility redeterminations and what we see on the horizon.
Very good. Mr. Grossman, go ahead and proceed.
Good morning, Mr. Chairman, members of the committee. Lee Grossman, State Medicaid Agent with the Wyoming Department of Health. So building off of the introductory comments from the director, first want to emphasize that, again, this is a return to business as usual. And we realize when we have suspended redetermining eligibility for 3 years, those that we serve, providers, et cetera, understand that and maybe get used to that pattern, right? But again, want to emphasize that this is really the last 3 years have been exceptional, and what we're doing now, while it's a monumental workload lift and implementation, is really the norm for Medicaid. So looking at in the omnibus presentation, this update starts on slide 18, and just looking at the next slide, you've already heard this general trend described from the director. But I think this visual is very helpful just in terms of illustrating how dramatic that increase has been. So before unwinding, enrollment in Wyoming Medicaid was really at a historic high. So that peak you see there of about 90,000. And you start to see in this data here the effects of unwinding and redetermining eligibility. So you see that significant drop, right? That stair step, if you will, reflected in the data right at the very end here. And that's, again, a very clear indication in terms of the work that you already heard we're tasked with from the director, right? Making sure that those who are truly eligible and qualify for this program are remaining on, and that folks who do not qualify anymore, we are sending them on to other health insurance sources for referral. We'll get a little bit more into the likely new baseline of that 60 to 75,000 that we're expecting or projecting once we're through this 12-month unwinding period. But just to give some historical context, I think that's a very helpful visual. And moving on to the next slide, we break that down by some of the specific eligibility groups. I won't go through each one of these. Of course, if there's questions, I'll be happy to take that. But we did try to highlight the areas where we have the largest coverage. So looking in particular at kids, pregnant women, and family care adults. Family care adults, just as a reminder, being caretaker relatives for eligible children on Medicaid. But again, it breaks that down into much more specific categories, including waivers, long-term care, nursing home, et cetera. These next two slides, looking at the total monthly expenditures and per member per month costs, really illustrate the point that the director mentioned in terms of, again, just overall costs. While we saw that enrollment increase, right, to, again, that historic high number, a lot of that was in more of the lower cost groups. So kids in particular who I'm thinking of here. So you see that per member per month, that the table or the graph, in the bottom left, really shows that significant decrease in terms of how much we're spending per member per month in Medicaid. Again, even while we see the overall expenditures and the overall enrollment grow. Looking at the next slide, this really just seeks to break down the expenditures by the two.
I think we have one question for you real quick.
Thank you, Mr. Chairman. Yeah, sorry to interrupt, but could you explain the stars on that? Back one more slide, I think. Yeah. Thank you.
Go ahead.
Mr. Chairman, Representative Hornack, thank you for that question. So as you can see by the note in the bottom right, with the largest modified adjusted gross income based eligibility groups versus age, blind, and disabled, that's really the nomenclature that is commonly used in Medicaid of modified adjusted gross income, or MAGI, being essentially children and family oriented eligibility groups. So our eligibility groups serving children, pregnant women, family care adults, and kid care CHIP programs are in particular the ones highlighted. And that's where we have the most numbers in terms of enrollment. So just to further drive that home, for example, children make up anywhere from half to 2/3 of total enrollment on Wyoming Medicaid. And so really just wanted to bring some attention to the fact that those are the groups that have, in the graphs where there's the largest volume essentially.
Mr.
One
Chairman,
more question. Oh, go ahead, Director.
just to add to that, Representative Hornock, if I may, both slides 20 and the previous one on 19, the groups, what we want to kind of carve out here are the folks on Medicaid that we would never expect to disenroll, for example, because of, procedural reasons or financial reasons. So nursing home clients, developmentally disabled kids and adults who are on our waiver programs, not as variable when it comes to income because of those categorical assessments on their clinical needs that are done for special programs. So you'll see, age, blind, disabled is a category. We have to have an acronym for everything. So we will say ABD versus kind of income adjusted eligibility groups, as Lee mentioned, like children and family care adults. That's really highly variable in terms of their eligibility, but also often with kids represents a significant volume of our enrollment. We anticipate the adjusted gross income categories during this Medicaid unwinding or eligibility redeterminations that we're talking about to be much more impacted in terms of disenrollment than we would those other categories that are permanently disabled, for example, and will likely remain on Medicaid due to their vulnerability, due to their clinical conditions. So those other ones that are more income based, we're seeing what we anticipated, which is a higher percentage of disenrollments after the public health emergency for those.
Representative, go ahead.
Thank you. Just for clarification, I think maybe to this point is, what are the income eligibility limits that your department looks at for people to qualify for Medicaid?
Go ahead.
So excuse me, Mr. Chairman, Representative Clouston. So those for these groups, they can be slightly different if you're asking for the overall federal poverty level limitation. But just thinking of children here in particular, that number, if memory serves, is right about 154%, I believe it is, of the federal poverty level for children age 0 to 5. And when you get to children age 6 to 18, that then goes down slightly to about, I believe it's 138, but happy to confirm those amounts if I've got those wrong off the top of my head. And as you heard from Mr. Fuchs earlier, again, that's dependent on household size in terms of what that exact number is.
Very good. I say green light. Representative Penn.
Thank you, Mr. Chairman. Could you help me understand why on slide 20, the kid care CHIP, we had nothing and then all of a sudden we had a lot?
Yeah. Mr. Chairman, Representative Penn, good question and observation. So prior to that time, Kid Care CHIP was administered by a third party, by Blue Cross Blue Shield. And at the time, essentially when you see that data all of a sudden start is when we started administering that as a Medicaid CHIP program. So administering that in-house in the Medicaid agency.
Follow up.
Thank you. So how did that come about? I mean, does Blue Cross still cover some of that, or now it's all CHIP and therefore state, or?
Mr. Chairman, Representative Penn, I can turn it over to my colleagues for background, but essentially that was legislative action.
Yeah, Mr. Chairman, Representative Penn, years ago, as part of the round of budget cuts that we went through, that was a proposal that had cost savings behind it to bring CHIP as an in-house administered program as opposed to a third-party administered program where we do an RFP and bid it out. Historically, we would put that RFP out and receive one bid. And ultimately, it was a legislative decision to bring that in-house and essentially cut that excess from the budget.
Oh, question, Representative Ward.
Thank you, Mr. Chairman. Mr. Grossman, so does that explain why the new baseline is significantly higher than the pre-December 19 baseline?
But
Mr. Chairman, Representative Ward. No, we have some additional language, and I'm happy to jump ahead to that point in the slides to talk about why we think that baseline is going to be higher.
okay, we'll wait with bated breath. Go ahead, proceed on.
With that cliffhanger. So right, we're almost there. I really just wanted to also highlight, if there's no other takeaway from, again, the information on slide 20, as you already heard from the director, a lot of continuity in those eligibility groups that serve older adults, people with disabilities. And where you see those significant increases, and likewise where we expect to see commensurate decreases in those overall counts. Again, if you think about who may have become newly eligible in 2020, again, we might be talking about folks who were laid off, job loss, decrease in wages, and became eligible for Medicaid at that time. So similarly, that's where we again expect to see the decrease as we go through unwinding. Moving on again back to slide, I believe I'm on 21. Well, I believe I covered that piece in terms of the decrease in our per member per month costs. Just wanted to again circle back to again being that trend being reinforced in again a larger number of children in particular who essentially cost less to insure through Medicaid. On slide 22, I think this just is a good illustration in terms of where we saw that expenditure growth. Again, the group labeled ABD, that stands for age, blind, and disabled. Think nursing home, Medicaid waiver folks in particular here. Approximately $4 million a month in terms of growth that we've experienced. But we think a lot of that is really due to rate increases. There were a number of rate increases that were implemented over that course of time. Enrollment, not so much in terms of really driving the change. Whereas where we see the on the right, that MAGI group, again, family and children's groups, but that increase of about 10 million a month, while the per member per month obviously decreased as we showed on the previous slide. Those overall numbers were obviously significant in terms of driving expenditure increases.
Mr. Chairman. Thank you. I'm looking at the decrease in the per member per month, and that looks really great. You think, oh, we enrolled a bunch more people and yet our costs decreased. Looking down on slide 22, we see that, we actually did see cost increase, but I suspect, I guess I would like your perspective on, it seems to me that COVID in itself decreased healthcare for everyone because people were told, stay home, stay home, stay home. And people did, people missed their cancer screenings. They missed all these things. And so it seems to me that generally our healthcare costs decreased because of that. People were told, do not use the system for a risk to your health. And so now as we're starting to normalize from that, people are getting back in and doing the things that they, catching up and doing, behaving a little more normally I worry that may be a little bit skewed to look at that and say, oh, even though our enrollment numbers went up, our costs actually decreased. I don't know. I guess I would like your perspective.
Go ahead.
Mr. Chairman, Representative Penn, I'll offer my perspective and invite my colleagues to do the same. Just for clarification, to make sure I'm on the same page, on slide 21, the graph in the top left, as you can see, total expenditures were certainly increasing month by month. Again, however, on a per person basis is where we were seeing the decrease based off of that change in population. I think the question you're asking gets into the conversation of care that may have been avoided during the pandemic, thinking in particular 2020, 2021. I don't know that as I sit here today, I can give you a real data informed answer. And again, would maybe look to my colleagues for a different perspective there. But that being said, one of the strategies that we took great care at the Department of Health and in Wyoming Medicaid was to make sure that folks had access to telehealth services. And I would be remiss if I didn't take the opportunity to plug that as proclaimed by the governor, this is Telehealth Awareness Week. So so just a good reminder there. And we saw significant uptake from that in that service modality, especially when we're thinking 2020 and 2021, dramatic increases of providers getting HIPAA compliant Zoom licenses. But again, from the limited perspective that we can provide in terms of what we saw on the Medicaid side, that was one avenue where we wanted to make sure folks had continuity of care. But there's no way to, I think, get around that all of us, right, regardless of payer source, had a different level of hesitancy, perhaps, in terms of how we receive that care.
Director.
Mr. Chairman, if I may, Representative Penn, you asked a good question. So as Lee mentioned, we have a lot of kids on Medicaid, and because of the PHE, we've had a lot of kids stay on Medicaid who might not otherwise have, and they're relatively speaking cheap to insure. So that per member per month cost, that's the reason, mostly the reason for that dramatic reduction there, in addition to some of those utilization dynamics. As Lee also mentioned, when you look at some of these graphs that do show that expenditure increase, a lot of which was offset by some of the enhanced federal match we received. But it's worth bearing in mind the legislature from 2020 to 2023 did authorize several rate increases in certain programs. One in particular for our developmental disability waiver providers. That is a significant part of some of these cost drivers. This previous session, the extension in coverage from 60 days to 12 months for our postpartum pregnant women group is part of that dynamic as well. So it's hard to tease out some of those in these macro graphs of the changes that happened in addition to, not being able to do eligibility redeterminations, but there's several factors that go into that. And my comments before that we haven't seen a utilization increase and thus a cost increase, I should probably clarify if I didn't before, we haven't seen a dramatic increase in cost that other states did see, partially because of the way they pay through their Medicaid programs, essentially paying health insurance companies on a capitated basis to take care of their Medicaid population, which in turn, if you have a federal policy that says you can't disenroll these folks now, and you have this artificially high number, other states have had significant financial issues because now they owe those plans, those health insurance companies, per member per month cost for them. So Wyoming is in somewhat of a unique position where you didn't see that graph on some of these slides really explode in the upward direction.
Okay. Oh, two more questions. Let's start. Okay, you guys fun now. Go ahead, Representative.
Thank you, Mr. Chairman. Question on one of these graphs. See a huge increase on the non-citizen qualifications expenses. How does a non-citizen qualify for Medicaid in the state of Wyoming?
Go ahead.
Mr. Chairman, Representative Clouston, great question. So you're right. You can see a significant growth there. This is a federally required eligibility group. And what this is emergency services only. So let's say that a non-citizen has a medical emergency, a car accident, what have you, and is treated right as would be expected to when they show up at the ER, et cetera. This is billed by that provider to Medicaid once obviously they have that information that they have been treating someone who is not documented. And again, we would cover just that particular service in that stay. So this isn't that someone has that event, they get onto Medicaid and they receive the same benefits as anybody else. Again, it's very limited in terms of scope and duration. And so through the course of the pandemic, just to reinforce the point, that if you look prior to that significant increase, pretty steady, right? In terms of load numbers under 100 statewide. The reason for that steady increase was we, again, could not disenroll anybody. So in terms of expenditures, we still had just that time limited expense, again, of that medical emergency where that was paid and no additional ongoing services. But again, due to the continuous enrollment requirements, we could not disenroll that individual.
Follow-up.
Thank you. So the other question is the CHIP expenses before the change, where were those accounted for when I look at these graphs?
Mr. Chairman, Representative Clouston, so they won't be here on these graphs. We can certainly provide a briefing on what CHIP has looked like pre and post taking it in-house to the Department of Health where it was contracted out previously. The numbers of children would look relatively similar. We, for the past several years, have always had around 2,000 to 3,000 CHIP children on that program. And just for edification for the committee, we have Medicaid kids as an eligibility group on the Medicaid program. And then CHIP is a program that is a slightly higher income threshold for children that wouldn't qualify for traditional Medicaid. Those enrollment numbers have been the same. You can see an increase during the pandemic, as we would expect, just because we're not disenrolling. We're not doing eligibility determinations, or haven't been. But we can get you cost figures there too. As I mentioned before, the reason the decision was made legislatively to bring the CHIP program in-house was largely because it did result in some cost savings for a variety of reasons. One, we typically pay lower rates in Medicaid, to be blunt, than private insurance does. So there's cost savings there. And two, our cost of administration in the Medicaid program is typically around 5% admin, where in private insurance companies, as you would expect, it's a little bit higher in administration. So we can certainly provide you that data of pre and post.
I could be wrong, but I think that in my file somewhere, I actually have a graph or some of that information when we made that change from your predecessor. Actually brought that to us, and yeah, anyway, I'll look through my files. Okay, Representative Horna.
Thank you, Mr. Chairman. So the total monthly expenditures have been risen from $42 million per month to $58 million a month. That's a difference then of roughly $190 million per year that we're expending to cover these Medicaid coverages, Medicaid costs, which is roughly almost a 30% jump. I you know, if I'm doing the math kind of right off the top of my head, but I know that the federal government has, with their ending of the public health emergency, I know in the past, the federal government has covered some of those costs. So I guess, am I seeing this right? And where are we going? Because Wyoming is continuing those coverages. We're looking at a 30% jump per year, or at least roughly $192 million in coverage for this. Where do you expect this to go? What are we going to see in the future with this? This is quite a huge jump. Thanks.
Director.
Mr. Chairman, Representative Hornock, thank you for the question. So to answer your last question first, as Lee mentioned, we expect in general, with a few exceptions, a return to business as usual. Now we can talk about why we think our baseline of enrollment will be slightly higher than it was pre-pandemic in some of the slides that will conclude the presentation. But you're right, that is the jump that you're seeing in enrollment and then per month cost is absolutely accurate. There's a variety of reasons why we haven't come to you all or the Appropriations Committee during the pandemic to say we need an emergency appropriation because we're blowing through our budget. Part of that is the enhanced federal match that came with the public health emergency. It was in broad terms about 6.2% additional to, so we're typically a 50-50 state in Medicaid. For the past 3 years, it's ratcheting down now. But for the past 3 years, we've been at a 56.2% federal match, which has absorbed a lot of that cost increase that you see. In addition to what I mentioned before, where we didn't know what to expect, but we really didn't see the dramatic increase in utilization during the pandemic, even though the enrollment numbers were higher. And in fact, as you all know, over the past 3 sessions, we've been able to work with the legislature and the Appropriations Committee to capture Department of Health reversions, money that we didn't spend largely in Medicaid, that was used on a one-time basis to finance what would have been exception requests in other areas. So the fiscal picture has actually panned out okay for the Department of Health and Medicaid, even given some of these increases that you see on a per monthly basis. But going forward, and it's a process over the remainder of this calendar year, really. We expect to see continued disenrollment of folks that were not disenrolled during the public health emergency. But because of things that we'll get to, just give you a few examples, the extensions of coverage that you all authorized, like the 12-month extension for postpartum coverage, and some federal policy that has changed, which is really more administrative in nature. We do anticipate, trying to be fully transparent here, we do anticipate a slightly higher baseline than what we had seen pre-pandemic. I'll caveat all that by saying, as you all well know, Medicaid, you cannot be on Wyoming Medicaid by nature of being low income. You must meet a categorical eligibility condition too, since we are a non-expansion state. But having said that, it's something that as we go forward, we know, and the caveat is that Medicaid enrollment also correlates to economic conditions. So as Lee mentioned in his introductory comments, on the onset of the pandemic and some of the economic consequences we saw from that, we do correlate that somewhat to increased enrollment where folks were qualifying for Medicaid, maybe more than they were before. It was the same with the 2008 financial crisis. You see a growth in all states of Medicaid eligibility and enrollment because more individuals qualify on the financial side for Medicaid, in addition to those conditions or categorical eligibility criteria. So when we say, here's what we anticipate the new baseline being, you'll notice frustratingly, and I always berate my staff, including Mr. Fuchs, for these wide ranges. When you see 60 to 75,000, hey, not very helpful, right? 15,000 give or take. But we want to do that because of those variables that we don't control, like household income, the state of the economy, et cetera, that can really impact that quite a bit. So again, long story short, Representative Hornock, I think the takeaway here is we will return to business as usual with our eligibility redetermination process as it was prior to the pandemic. That's what we're going through now. It's a phased approach, but that's where we will get. But because of some of those variables, we do anticipate a slightly higher baseline of enrollment in Wyoming Medicaid than we saw before. Does that answer your question, sir?
Follow up. Thank you, Mr. Chairman. Yeah, if I could follow up. So I know that eligibility is rising a little bit. Are we going to then see a fall back to somewhere near the $42 million a month mark, or are we going to continue to rise over the years with this? I do know that, like the postpartum expansion that we did, I do know that, obviously we need to account for those costs. And with the rising eligibility or rising number of people enrolled, there's obviously a rising cost. Now, the per member per month then drops, it makes sense. But, over the long term, then when you talk about seeing those numbers kind of level out, what are we talking about leveling out, and where do you expect that to be?
Go ahead, Franz.
Mr. Chairman, Representative Hornock, Franz Fuchs, Policy Analyst, Department of Health. So, Mr. Chairman, if you look at slide 21, that top graph, as you noted, our monthly expenditures have increased from a baseline around $42 million to $58 million. What we try to do on slide 22 is decompose that a little bit. So that's about $16 million a month, right, that we're trying to account for. But there's been a lot of things that have happened over that time period. And so we look at the ABD side on the left, and that's because that group has not really been affected, as the director mentioned, by the unwinding or the PHE. Those eligibility groups like nursing home have been relatively constant because it's based on clinical need, not income per se. So the increase in the cost for the ABD has really been attributable more to rate increases, like to IDD providers, nursing homes, that the legislature has appropriated over the past few years. So to decompose that $60 million, we're basically estimating on $4 million of that increase per month has been due to those rate increases. And then if you look at the graph on the right, the MAGI groups are the ones that have really been affected by the PHE and will be affected by the unwinding. We anticipate there's some of that has been also affected by the rate increases, right? So we have state budget cuts and restored budget cuts to Medicaid providers broadly. So we're estimating here about $2 million is maybe attributable rate increases. But then there's $10 million that's attributable to enrollment increases. And so you can see it's about 12 million total from baseline to now, right? As we start disenrolling. So our WAG, as it were, for where costs are going to be on new baseline would be likely a decrease in around probably $8 million a month, because we're not going to be disenrolling going back to the pre-pandemic baseline. That baseline will be slightly higher. So my guess right now, without any knowledge of kind of how the trend is happening, because we've only had 1 month of this so far, would be that decrease into, an increase above baseline, basically halving. So from 42 to about 50. If you're putting me on the spot right now. And that's just based on, how to separate out the rate increases from the enrollment increases, and then trying to guess where enrollment's going to end up post PHE. And I believe Mr. Grossman has a final slide on kind of explaining why we think the baseline will be slightly higher.
Go ahead, Mr. Grossman.
Mr. Chairman, I'll just skip right ahead to, let's see, this is slide 23, where we talk about the why we think this baseline is going to be higher than pre-PHE. So again, to the director's comments, we understand there may be some frustration of 15,000 is a significant range, but really there's a few key influences here. So something that we think is will drive those numbers down is just the state of the economy, and assuming no recession. As you already heard from the director, for example, in 2008 and those time periods of economic downturn, we expect to see higher Medicaid enrollment. But some of the upward pressures include the postpartum extension for pregnant women that we've already spoken about here earlier in terms of legislative authorization. Ex parte, or also known as automatic renewal requirements. That's a very nuanced and detailed area. The long story short here is that this is a federal requirement for what we do administratively when folks are up for renewal on Medicaid. And we have requirements and an obligation to check reliable electronic interfaces. So for example, just one that's a relatively recent addition is an electronic interface with the Department of Workforce Services to verify state wage data. Those types of things to see if we are able to confirm those income sources, for example, to make a determination on someone's eligibility status. And lastly, this is a piece of the director mentioned ongoing or evolving federal guidance, and this last one is really the most pressing and latest edition of this is how we look at individuals on a case versus an individual level determination. Again, this being a federal requirement as well, and something that we're adjusting to, if you will, sort of midstream during the unwinding, to which I give my eligibility team back in Cheyenne a tremendous amount of kudos. But really what a situation that I think can help illustrate this is, let's say there's a renewal that's not returned, or it is returned, but the income has changed for a household where you have both a parent and children who were eligible previously before that renewal came up. Well, instead of that entire household being closed, if we can renew, say, the children, again, as a reminder to some earlier conversation, that's a higher income limit. Then making sure that we're able to do that, and that those children can remain eligible on Medicaid. So with those factors combined, kind of looking at those in totality is where we expect that new baseline after we're finished with this 12-month unwinding period to be higher than that 50 to 55,000 range we saw prior to the pandemic. But again, that range, and I'll defer to my colleague, Mr. Fuchs, here in terms of what else could influence that. But we would expect the farther we get into unwinding for that range to get a little bit more fine. With that concludes the comments. Thank you for your patience in getting to that cliffhanger. I hope it delivered in terms of finding some of the reasons why we expect that number to be higher. And with that, we would stand for any questions.
Representative Yan.
Thank you, Mr. Chairman. So I learned this week that some states are with their ex parte renewals, they have determined some of their adults are not eligible, and then they disenroll the entire household, even though children were eligible. So it sounds like you're avoiding that. So that's great to hear. Is it Do you expect any roadblocks in being able to get responses from folks, especially those folks where it's harder to find their contact information? And what sort of outreach are you doing to try to reach those folks where we don't have the contact information for them?
Mr. Chairman, Representative Yin, great questions. And if I can just briefly touch on the first point. So for example, you may have seen news release from our offices or other press articles. Where about 10,000 individuals were disenrolled with the first batch of what are called procedural renewals. And then this gets to your point of how we are manually looking at all of those closures. So you can, imagine the time and staff intensity. And that number is actually now closer to 7,000 once we manually work those for that exact scenario, right? To make sure that the entire household, if that case and all eligibility closed, that it was done properly. And for example, the children did not remain eligible. So just a brief update there. And on the outreach perspective, that's something really since the beginning of this calendar year that we've been very focused on. So before we started the unwinding, a lot of the communication that hopefully you may have heard or come across was, please make sure your contact information is up to date. Over the course of 3 years, we recognize folks may have moved, be it in-state or out-of-state. And so we need to make sure that we have a reliable way to contact you. And that's really been a key push and an area of emphasis for us. And you may hear later from our partners at Enroll Wyoming in terms of some other efforts aside from just the state government perspective. But from a communication standpoint, perhaps it might be helpful. Let's say someone is renewing for Medicaid. Like, what does that contact look like? So first of all, I mentioned the automatic or the ex parte renewals. So that happens all in the background of systems doing that work and trying to verify what we can to renew someone. So based off of that information that we get, someone can actually be renewed at that point. Or if we're not able to do so, we'll send out a pre-populated form of here's the information that we have and the information that we do not have that we're requesting from the individual. That happens 60 days before the renewal date. We send out text messages prior to the pre-populated form that go out. And we know we have data to know those are actually being received and folks are getting that communication. And then we'll also call, let's say, if mail's been returned to try to track that updated information down. So just a brief overview, but hopefully just to help illustrate that it's not just a simple mailing that goes out and we cross our fingers or hope that someone returns it. We're actively trying to make sure, again, that folks know it's really critical to update their information with us and those different methods of outreach. So from my perspective, while we're still seeing significant volume of folks not returning that information, which could be for various legitimate reasons, it's the sort of outreach or the hand that I think the department is extending to try to provide a multitude of different options has never been more robust than it is over the course of this unwinding.
Representative Yan.
Thank you, Mr. Chairman. Thanks for all of that. I think that's very good to know. I also learned that Georgia allows their providers to send in updated contact information. So it lets the provider, when someone comes in, they're enrolled in Medicaid, the provider can just ask and then submit it with their claim, their new contact information. Is that something that we do here? Would that be useful to let patients update their contact information through their provider?
Go ahead.
Mr. Chairman, Representative Yin, to my knowledge, that's not a practice we have, but I'm happy to take that back in terms of what that could look like, logistics, et cetera. So thanks for that.
Senator Hutchins.
Thank you, Mr. Chairman. Question on the children, when you say that the parents could not qualify anymore, because I'm assuming their income has gone up, what makes the child eligible to still be on, for the novice here, on Medicaid?
Go ahead.
Mr. Chairman, Senator Hutchings. So examples are what my mind connects with. So let me see if I can provide one to help out here. So we talked earlier today about the federal poverty level in relation to behavioral health redesign. Well, for simplicity's sake, the limit for the Kid Care CHIP program, so let's take in Medicaid and CHIP, is 200% of the federal poverty level. Family of four, that's about $30,000 in terms of income. So let's say during 2020, during the pandemic, let's say breadwinner or breadwinners of a household lost their job, were unemployed for a duration of time, applied for Medicaid benefits, having essentially no income at the time, likely that entire household would have been eligible, again, assuming that the adults were the caretaker relatives of those kids. Fast forward where it's time to renew now, and those, let's say the parents are now employed and are under that 30,000 amount, but over what the eligibility limit is for family care adults, which is about 54-ish% of the federal poverty level, so much lower. That's an area where you would have had a family where everyone was eligible during, let's say, the height of the pandemic. And now they're still under that threshold where the kids would remain eligible for Medicaid and CHIP, but the adults wouldn't any longer. I hope that example helps illustrate such a circumstance that we see every day.
Further questions for the department committee? Question?
Thank
Go
you,
ahead,
Mr.
Dr.
Chairman. Just for clarification, when I look at the slides, two of the reasons that costs are going up are rate increases. And then a couple times you also mentioned the Medicaid expansion for postpartum women. Memory, postpartum women expansion was like 125,000 a month would be the increase to the state of Wyoming. I mean, for perspective, rate increases is 4 million a month. So I guess, am I correct in those figures? I guess I just want everybody to realize that the number for the postpartum at 125,000 a month was a very low cost, right? And that's what we voted on compared to this 4 million a month. Okay.
Go ahead.
Mr. Chairman, Representative Clausen, I got a nod from the director to my left, so I assume that's also correct. And I think the thing to highlight here is just in terms of enrollment numbers, that 1,000 to 1,500. Again, from a cost perspective, I don't think that change in particular provides a lot of upward pressure. Again, just in terms of where we might see some of that additional post PHE or unwinding, I should say, enrollment.
Okay. No further questions, committee. We'll let you guys get out of the hot seats. Oh, where is one? You're not out of the hot seat yet. Sit down, Director.
Sorry, Mr. Chairman, thank you. Just interested to know so about the only one that has gone down is the nursing home. Can you explain why that is and what is happening there?
Go
Mr.
ahead.
Chairman, Representative Hornock, I'll take an initial swipe at that and ask my colleagues to add anything. Really, that's primarily due to the unfortunate increased mortality that we saw during the pandemic, and nursing homes really being hit hard there. But Mr. Fuchs or Director.
Go ahead, Franz.
Mr. Chairman, Representative Hornock, I'd also add that, so you can see on the nursing homes, a little bit of a notch right around the end of 2020. That really is the significant mortality effect, and that did have a unfortunate decline in enrollment there. But you'll also note there's been a sustained decline past that notch. And we don't know exactly what's going on, but the arrivals to Medicaid long-term care in general have slowed since the pandemic. And whether it's because nursing homes, due to a lot of the restrictions that were put in place during the pandemic, are significantly less hospitable. I mean, as far as visitation, PPE, all the medicalization that's happened since, that might be a factor. Obviously, people probably don't want to go to nursing home at all, but that certainly made it less attractive. So we saw actually a decrease in the arrivals to Medicaid long-term care generally, and that's an effect we believe will rebound eventually. We think those arrivals will go back up, and that kind of speaks to our aging and long-term care presentation at the last meeting you had, trying to project those out to the future. But those hopefully answers your question on the nursing home decrease.
And I would say keep that question in mind as we move into the afternoon. We're going to talk more about long-term care and senior services. So that may be something that some of those folks can address as well. Okay, Representative Young.
Mr. Chairman, thank you. Just one request for you guys. For these graphs, I think these graphs are great. Would we be able, because inflation has been significant, these from 2016 to 2023, would we be able to get these graphed against an inflation baseline just to see what it compares to inflation?
Go ahead.
Mr. Chairman, Representative Ng would be happy to do that. I will note though, just for the committee's reference, we don't index our Medicaid rates to inflation. Any increase in the Medicaid rate is due to legislative approval and appropriation.
Very good. Okay, this time you can really get out of the hot seats. I'm going to ignore the hands around me. Mr. Menser.
Great stuff.
Wow,
Chairman, if you could just.
we'll pass those out.
I'll make it happen.
That's a co-chair responsibility. He'll handle it. Welcome, Mr. Menser. Introduce yourself and tell us everything good about today.
Mr. Chairman, I'm Jason Mincer. I run the Enroll Wyoming program. We are grant funded from the Center for Medicaid Services and at the federal level. And our role is to work with folks across the state who don't have health insurance or who are underinsured. We are a resource to them to allow them to look through their options and to choose an option that works for them. This comes at no cost to these consumers. My staff and myself do not have sales goals or commissions, anything like that. Cover the entire state, and we are there if folks choose to move forward with a Medicare, Medicaid, or Marketplace application. We can provide them with help with those applications as well. I'm going to mention some things about Medicaid and some things about Marketplace today as well. And just want to first of all, follow up on the conversation around Medicaid unwinding or the re-registration portion of things. The part of this that's been difficult for the folks enrolled in Medicaid is that communication piece. We've talked a little bit about that already. Roughly 1/12 of the Medicaid population is receiving a letter and a text and a phone call and the things that the Medicaid department mentioned each month, saying that if they do not reapply and they are not accepted, that they will lose their Medicaid coverage. And as we've mentioned before, many of those enrollees have moved or changed contact information, and the Medicaid department mentioned that 10,000 people were dropped off the Medicaid rolls in the first month that was implemented. And so we've been working with the Medicaid department to try and promote and educate people that, again, they need to check their contact information and make sure that that is accurate so that when that time arises, they are able to look at those applications and make sure they reapply. I would ask, the members of this committee, as you're out in your communities, please do remind folks that and in public events that is an option, that they can either call the Medicaid office or if they choose to log in through the portal, they can look in the portal to see that their information is correct. As we've also talked about, many people will not qualify for Medicaid coverage going forward, even if they do reapply. And I want to make it clear that those folks, if they do make over 100% of FPL, will qualify for Marketplace plans. And they will qualify for what's called a special enrollment. And I'll talk about, open enrollment versus special enrollment in a minute. But there will be a lower cost option for health insurance that they will qualify for. Just want to, again, thank our partners at Medicaid for the communication that we have with their office and the ability we have to work with them to double check everything that we're sending out to make sure that things are accurate. I give them a lot of credit for how they've handled this situation and the pure volume of applications that are going to come in and those things as well. So I want to thank them for that. Moving on to Marketplace health insurance coverage. This was started about 10 years ago. I think most of you know that healthcare.gov is the marketplace. That is, and it was intended to provide a place where folks could compare insurance, health insurance on an apples to apples basis. And they've been relatively successful with that. The big advantage to marketplace health insurance plans are that they are the exact same plans that are sold in the private market. In Wyoming, we have 2 insurance companies in our marketplace. Those include Blue Cross Blue Shield and Mountain Health Co-op. And again, the product that is sold in the marketplace is the exact same one they sell on the private market. But there are subsidies from the federal government that provide discounts for that health insurance. I hinted about this before, open enrollment versus special enrollment periods. And the thing that I really wanted to stress today was that we're coming up on the open enrollment period. And I know policymakers receive calls from constituents saying, I don't have health insurance. What can I do? It's a good time to start having those conversations because the open enrollment period for the marketplace health insurance plan starts on November 1st, runs through the middle of January. And a majority of people who need health insurance can only apply during that time period. Again, we've talked about those folks who are dropped off the rolls of Medicaid being ones who qualify for coverage outside of that open enrollment period. If folks move, if they get married, if they have a child, there are some other instances where they might be able to qualify after January 15th, but there are not many of those that happen. I've hinted at this as well. We are a resource to the state. We would like more referrals in terms of more people we can visit with. We have the staff to handle that and really do enjoy that part of our work and being able to make substantial changes in people's quality of life and their access to healthcare. I want to reference I'm going to call it a packet of information that I handed to you all. And I feel a little bit gimmicky as I say this, but there's a couple of different things that are included that might be helpful as I talk about those referrals. Both the clip that you have there and there's a magnet there. If there's a place in your house where you take phone calls and want to remember how to refer, our website is there. Throw that up on something that's magnetic. And then I gave you a second one that is an actual magnet for your office as well. Take that or leave that. There is a pamphlet included there as well that has more information about the work that we do than I've explained today. Just a final resource piece that I have is that enrollwio.org is our website. There's a ton more information there. I have a couple of different takeaways for the committee. One is, if folks are contacting you about health coverage, we are the resource that can help them. And I just want to make that clear. And if you don't have either one of those things in front of you and need to refer, the easiest thing you can do is use 211. Folks, they can get folks to any of our navigators who do this type of work and super proud of our partnership with 211 and the help that they provide. The second piece, as I mentioned before, is, the more we can do to spread the word about the Medicaid unwinding and to make folks aware that they should be watching their mail and opening their mail for Medicaid, as well as checking their contact information. The fewer people we'll have who will show up to a pharmacy or to an appointment and learn that they are no longer covered. I'd also like to thank the committee for their time this morning.
Yep, and you're not out of the hot seat, I believe. Oh, sure, has a question.
2 questions, Mr. Chairman.
I can do that.
First, did you say there's only 2 people on the exchange, Mountain Health and Blue Cross? Cigna's not on the exchange?
That is correct.
Okay.
Cigna is not on the exchange. There are only 2.
And then second question, is there any kind of agreement with the Department of Health if they're unwinding, 1/12 a month? Do they let Enroll Wyoming know who's getting those letters so you can coordinate with those people? Or are you just kind of shooting out in the dark at who's going to be disenrolled and how to meet that? Is there any coordination on knowing who they're dropping and who you should go be talking to?
Go ahead.
So the answer is indirectly yes, but directly no. There are HIPAA concerns and a variety of other things that I suspect caused that to be of large concern for the Wyoming Medicaid Department. On the other hand, because our grant comes from CMS at the federal level, we are given the names and contact information of about 100 people each week who have dropped off of the Medicaid rolls. And just like the Wyoming Medicaid Department, my staff is making phone calls, sending text messages, emails, and what am I missing? And sending physical letters to those folks. That being said, it is the same exact contact information that the Medicaid department had. And so, you know, we are picking up, I would say, somewhere around 10% of people are responding in some way, shape, or form, either saying they do have coverage at this point, or that they do need some help. But roughly 90% of the folks that we're contacting are not getting back with us.
Very good. Further questions for Jason? Representative Penn.
Thank you, Mr. Chairman. Mr. Minster, could you help me understand a little more background on Enroll Wyoming and where it came from? Where does your funding come from? I assume you probably are not volunteer. Like, how do you afford to send out letters? Those types of things.
Sure.
Mr. Menzer.
Representative Penn, our funding comes from the Center for Medicare and Medicaid Services at the federal level.
Follow up.
I was just looking at your business card that you passed out. Thank you. I just see that you've got Cheyenne Regional Medical Center on there as well. What's the partnership there?
Sure, Mr. Chairman and Representative Penn. In technical terms, Cheyenne Regional Medical Center is the lead agency for that grant. They accept the revenue that comes in and provide us with some on-site help with the HR team and things like that.
Follow up.
Thank you. So does Cheyenne Regional have to fulfill or meet certain requirements in order for them to get the grant, and then they disperse it? Is it like a block type situation, or how do they get the grant to then move to you?
Sure.
Mr. Menzer, and I think there may be a lifeline that knows a little bit about that. So go ahead.
Mr. Chairman and Representative Penn, many federal grants are run through nonprofit organizations who administer those grants. There's hundreds of pages of documentation on things that Cheyenne Regional must do to fulfill the objectives of that grant, and I'm the one responsible for that fulfillment with the help of CRMC staff.
Mr. Kocher.
It's a competitively bid grant, and every state has an entity, often a nonprofit. Here in Wyoming, we don't have maybe the same significant statewide entities that many other states have. And so trying to get a grant of that level for people to oversee. I don't even know how many people competitively bid on that Enroll Wide, maybe you know, but every state has a cooperating organization on behalf of the federal government, CMS, to administer, people to sign up on the exchange, and CRMC certainly put out a proposal. And so it's a competitively awarded grant to whoever has the capacity to oversee it. Should that be correct?
Mr. Co-Chair, thank you for filling in the details.
Very good. Senator Hutchins.
Thank you, Mr. Chair. Mr. Minster, question. What I'm seeing is you have an office where there's someone over here trying to reduce the rolls on Medicaid, and someone on the other side of the pillar trying to increase it. Is that what's happening?
Mr. Menzer.
Mr. Chairman and Senator Hutchins, I don't know that anyone is trying to increase the numbers on Medicaid or increase the eligibility for Medicaid. My role in working with the public is to show them the options that are in front of them, and if they qualify for a program like that, make them aware that they do qualify and that they have the option of submitting that application. many people choose to do that. I think, and it may not be my role to say this, but the eligibility for Medicaid and the lack of re-enrolling in Medicaid did change the number of people on Medicaid, but the eligibility requirements did not change much pre-pandemic versus post-pandemic. The maternity portion of things has changed a little bit, but Wyoming eligibility for Medicaid has not changed for the most part.
Very good. Okay. Okay, thank you, Ms. Spencer. Appreciate seeing you here today. Turn your light off if you would. Okay, public comments. Anyone in the room wish to comment on this topic? Wow, they're already sleepy. Imagine what they're going to be like after lunch.
I thought it'd be a lot worse, but it's been going really.
Okay, anybody online that wishes to speak with us? There is.
Yes. Bringing her in. Cartwright.
Ms. Cartwright,
Take her a second to get in here.
we're anxiously awaiting seeing your smiling face.
There you go. Yep.
Okay, I think you're on. Go ahead, ma'am. Oh, I can't hear you. I think you're muted.
You'd think I'd be a pro at this by now. I'm sorry.
You are. Go ahead, Ms. Cartwright.
I'm Jan Cartwright. I'm a board member of Healthy Wyoming. As you know, my organization is focused on expanding Medicaid to low-income childless adults. Healthy Wyoming also wants to make sure that people who are currently eligible for Medicaid can access that coverage. In the discussion today, we very much appreciate Wyoming Medicaid for their Herculean efforts to redetermine eligibility after the public health emergency has ended. And we thank Enroll Wyoming for its work to also contact recipients to file their paperwork if they've been procedurally disenrolled and may not even know that they've lost their coverage. Along those lines, because the majority of those already disenrolled in the first 4 months were children, Healthy Wyoming would request that all available resources be mobilized to inform and encourage people who have lost their coverage to submit their paperwork so that the redetermination can be completed. Thank you, Mr. Chairman.
Questions for Ms. Cartwright? Go ahead, Representative Penn.
Thank you, Mr. Chairman. Mrs. Cartwright, I'm going to ask you the same question as I asked our last individual. Where does the funding come from for Healthy Wyoming?
Healthy
Go ahead,
Wyoming.
Ms. Cartwright.
Okay, I'm sorry, Mr. Chairman. Again, I should be good at this. Mr. Chairman, Healthy Wyoming is a coalition of organizations who all have the same goal of expanding Medicaid. We are also funded by, and we are building now our own 501c3. Until now, we've had funding go through a lead agency. So as I speak to you today, I'm one of the first board members of the newly formed organization. And our funding comes from a national organization called Community Catalyst. So very much voluntary. We have to reapply for the funding on a regular basis.
Okay, thank you. Further questions, committee? Thank you for joining us, Ms. Cartwright. It's always a pleasure to have you with us.
Thank you, Mr. Chairman.
Further public. Anybody else online, Katie? You're saying no, Nicole Chair saying no. It's unanimous. There's nobody else online. Anybody else in the room wish to comment on this topic? Okay, there's no associated legislation committee, so we'll move on to our final agenda item for the morning. I would remind the committee, we have a hard stop this afternoon, so we need to make sure we keep things moving. We do have a tour of the newest Wyoming hospital this afternoon here in Saratoga. So with that in mind, LSO, we have 2 bills about nursing home administrators. If you would like to, for somebody, go ahead, you can sit over there. That's fine. Go ahead and present those to us if you would.
Chairman Baldwin, members of the committee, Katie Adams, LSO. This is 24 LSO 0149, Nursing Home Administrators Temporary Licenses, Working Draft 0.6. In June, the committee directed LSO to draft a bill authorizing the Board of Nursing Home Administrators to issue temporary licenses. The board provided language to the committee and LSO worked with the board on that language and modified some of it through the LSO review process. On pages 1 to 3, section 1 of the bill creates a new statute to address temporary licenses for nursing home administrators. Subsection A authorizes the board to issue a temporary license under 3 circumstances. Under paragraph 1, the board may issue a temporary license to an applicant for a license who has provided all of the information required for a license and is awaiting the results of the applicant's criminal history record background check. A temporary license issued under paragraph 1 expires when the board receives the results of the applicant's background check and either issues or denies the application. Under paragraph 2, the board may issue a temporary license to an applicant for a license pending completion of the experience and examination requirements established by rule of the board. A temporary license issued under paragraph 2 is valid for not more than 6 months, and no applicant shall receive more than 2 separate temporary licenses under paragraph 2. Under paragraph 3, the board may issue a temporary license to an applicant for a temporary license who, by training or experience in the field of institutional administration, the board determines is qualified to serve as the administrator of a nursing home that does not have a licensed administrator. And a temporary license issued under paragraph 3 would be valid for a period established by rule of the board. On page 3, subsection B specifies that the holder of a temporary license is authorized to serve as a nursing home administrator for the period that the temporary license is valid. Subsection C provides that the holder of a temporary license is subject to the same standards of conduct as a license holder. Turning to section 2 of the bill, this just makes 2 conforming amendments. So section 3322-108 is amended to require the board to develop, impose, and enforce standards which must be met by individuals in order to receive not only a license, but also a temporary license. And then on page 4, section 3322-110 is amended to clarify that the holder of a temporary license will not be subject to criminal penalty for acting or serving as a nursing home administrator. Section 3 of the bill requires the board to promulgate rules. And then finally, on page 5, section 4 of the bill contains a split effective date. And with that, I would stand for any questions.
Questions on the substance of the bill, committee? Representative Penn.
Thank you, Mr. Chairman. So the original section 1, creating this statute, temporary licenses, is this applicable only to nursing homes, or is this broadened to other licensures?
Go ahead.
Chairman Baldwin, Representative Penn, I believe it would only apply to nursing home administrators. I'm not sure if that answers your question, and it may be, if I can't answer it, it probably is something that the board can answer.
Representative Penn.
Thank you. I was just quickly trying to pull up that statute. It looks like that comes 3322-110 is for nursing home administrators. So I think that's probably the case. We're just talking about nursing home administrator licenses. So thank you.
I believe you're correct. It's specific to that.
Okay.
So.
Chairman Baldwin, Representative Penn, if I can clarify, that set of statutes does just apply to nursing home administrators. It's in Title III, which is professions and occupations. And then it would be added to that set of statutes, 3322-101 to 3322-110, all address nursing home administrators.
Very good. Further questions on bill, Mr. Co-Chair?
No, Mr. Chairman, I was just going to say, we discussed this at our Evanston meeting and asked for this draft to be brought forward. And we do have Ms. Reed from A&I and I believe some government affairs people also here, whichever order you want to go. But certainly Ms. Reed is here if you want to call on her first.
Sure. Let her in.
She is in. Joanne, if you're available. Okay.
Okay. Proceed. If you can hear us, Ms. Reed.
Good morning, Mr. Chairman, members of the committee. I am Joanne Reed. I am the administrator for the A&I Professional Licensing Division. I am here just to answer any questions you might have on this proposed language.
Very good. Does anybody have any questions for Ms. Reed? I think it's your lucky day. I don't see any questions. Okay, do we have anybody else which online? Nope. Anybody in the audience to which comment? Mr. Bowley, come forward.
Mr. Chairman, committee members, Eric Foley with Leading Age Wyoming. And I won't belabor the point, but if you'll remember in Evanston, we introduced this topic and there was no motion to move the bill or the draft of the bill. We revisited the second day. I think this is a really important piece of legislation. It's just a quick fix for a situation that we're actually seeing. And I don't sit on the board of nursing home administrators. I used to, but in my current capacity, I don't work for them, but I do represent nursing homes in the state. We've had experiences since July, as a matter of fact, or June, when we met last, where we've needed to issue temporary licenses and haven't had the ability to do that. There's a tremendous amount of turnover right now in long-term care. We've got folks that are in the administrator and training program and are doing other things. We're also seeing delays with the background checks. And so this is just a great, an easy fix for a situation that we're finding ourselves in. And I'd ask for your favorable consideration to move this forward as a committee bill to be considered during the legislative session.
Mr. Bullock, I guess I have a question. My question is this: what is the consequence if we have a nursing home that loses their administrator and we don't approve this, we don't have a temporary, what's the consequence to that nursing home? If we go 3 months, 6 months and we don't have somebody?
Mr. Chairman, that's a really good question. And it could be all over the board. I mean, literally, if they can't find someone to fill that spot, they could potentially lose their ability to admit patients. A lot of them go out and they'll hire an interim administrator, which is expensive and doesn't really help. But what I think the important part of this is we have folks that want to belong to those organizations that are in the process of getting their permanent license. And this creates a pathway forward for them to do that. But it could have really detrimental impact on the nursing homes in our state.
Thank you. Further questions from Mr. Bulloy? There's one. Representative Hornock.
Thank you, Mr. Chairman. So is the problem we're trying to solve with this, the current problem we're facing, is it that the standards for the nursing home administrator are extremely high and there's very few people that meet them? Or is it that it's taking so long for a nursing home administrator to be approved in that role? I mean, we're trying to help on one side by allowing further time for a nursing home administrator, but also the standards that these administrators need to meet, are they very high? Is there something we can do on that side as well?
Mr. Chairman, Representative Hornock, it's really just a simple fix. The test hasn't changed in the 25 years since I took it. The training, it requires 6 months of training. And I think really what it is that the Board of Nursing Home Administrators thought they had this authority at one point, and now they found out that they can't. So we're just trying to fix that quickly so they can do things that they thought they had the authority to do in the past. The standards haven't changed. And I would say that when it comes to running a nursing home, the standards should be pretty high. You're taking care of a vulnerable population, but it's a 6 months training period. But what we're really trying to address though is just where we run into that situation where they lose their administrator for whatever reason, and they're in the process of transitioning to someone new, and they need that temporary license while they wait to get their permanent license.
Very good. Further questions, Representative Penn.
Thank you, Mr. Chairman. Anyone can correct me if I'm wrong, but I think that we issue temporary licenses for in other avenues. I know myself as a nurse, when I had my application in, everything was done, my education was complete. I'm just waiting for a return on that, which could be a few weeks. And I've got a job and I'm anxious to work and I'm needed. I get a temporary and did get a temporary, and so I can work until I get this license. And then this bill also says that, so it expires when either the license is issued or it's denied. So if their license gets denied for any reason, then so would the temporary license.
Comment, Mr. Bullock.
Mr. Chairman, that's a great description, Representative Penn. Thank you.
Very good. Further questions, comments? See none. Thank you, Mr. Bullock. Is there any further comment in the room? Committee, what's your pleasure on this bill? Moved by Swanser, second by O'Hearn.
To make a committee bill for the 2024
Make
budget
that a
session.
committee bill for 2024. Committee, comments, amendments, questions? Seeing none. Let's do a roll call vote, please, Katie.
Mr. Chairman, this is roll call for 24 LSO 0149 Nursing Home Administrators Temporary Licenses. Senator Barlow,
Excused,
Senator Bouchard,
excused,
Senator Dockstetter, Senator Hutchings, Representative Chadwick. I'm sorry, repeat.
Aye.
Representative Klauston,
aye.
Representative Hornock,
Aye.
Representative O'Hearn,
Aye.
Representative Penn,
Aye.
Representative Trujillo,
Aye.
Representative Ward,
Aye.
Representative Yin,
Aye.
Co-Chairman Zwanitzer,
Aye.
Chairman Baldwin.
Aye.
The committee has voted to sponsor that.
That will be sponsored in 2024 budget session. That leaves us to one final bill draft. With number 151, certificate of need repeal, if we can get that presented to us by LSO, please.
Yes, Mr. Chairman. Mr. Chairman, members of the committee, this bill draft is entitled 24 LSO 151 Certificate of Need Repeal. This was requested at the last meeting in Evanston. This bill draft repeals statutory language regarding nursing home beds. If this bill draft is enacted, there will no longer be a prohibition on the expansion or construction of nursing home beds. And the language as it currently stands is highlighted on page 2 in the staff comment in case you want to look at that. And then also the definition of construction area was removed because it's only used within the repealed statute. And then F and G are also being repealed because they're no longer relevant if B and C are repealed. And then section 2 provides for an effective date. And I would stand for any questions.
Questions for LSO committee on the bill draft. Representative Penn, I see you reaching for the button.
Thank you. Can I just quickly be reminded why this may have been there in the first place?
Anna, go ahead.
I'm not entirely sure why Wyoming has a certificate of need statute. I think it was mainly just to ensure that there wasn't too much of an influx of too many nursing home beds within a county, is what I understand. And I think that's correct.
And I believe we'll bring up Mr. Bull who can
And-
comment on
and-
that further.
I'm sure he would have a better answer than me.
Questions specifically on the bill draft committee? See none. Mr. Bowley, would you like to come up and address that question for us?
Mr. Chairman, committee members, Eric Bullock, Leading Age Wyoming. It's my understanding that certificate of need was in place in all states for both hospitals and nursing homes. I think it was federal. And then 30 plus years ago, we repealed statutorily, we repealed the hospital certificate of need, but this one has been in place since then. And it is to help limit the number of beds, make sure we don't overbuild, make sure that we can meet the needs of the community. That's my recollection.
Director, come on up. We have 3 seats, 4 actually. If you'd like to invite anybody else up, please feel free.
Thank you, Mr. Chairman. Mr. Bowley's right. I probably can't give you the exact genesis of the certificate of need for long-term care. But in general, on the federal side, given that the vast majority of long-term care costs are generally borne by public payers, either Medicaid or Medicare. For example, in Wyoming, Medicaid pays for about 65%, maybe closer to 70% of all nursing home bed days in the state. And so certificate of need mechanisms are generally to put a check and balance or a barrier in place to ensure that, as Mr. Bowley mentioned, we don't see overcapacity or overutilization of institutional long-term care services than are needed in a geographic area. Secondly, certificate of need really became discussed quite a bit decades ago when home and community-based services as an alternative to institutional care were being legislated and promulgated on the federal level. So think of our long-term care waiver programs that offer clients who would qualify for nursing home level of care services in their home and communities. Certificate of need was always discussed in context of those programs as well, that there can be alternatives to long-term care placement. And so that's my understanding of where certificate of need laws came from. As we discussed at our Evanston meeting, this certificate of need law is essentially enforced by my department through our Office of Healthcare Licensing and Survey. So if we receive an application or a proposal for a nursing home bed expansion, we will look at the letter of the law that you have in front of you to determine if what occupancy standards are in that geographic area. And therefore, if legally by state law, we can permit an expansion of a nursing home or construction of nursing home beds. So this would effectively repeal that.
And my question, Mr. Director, is have we had any of those applications? And what is your projection for any applications? If you can provide that, you may not be able to.
Mr. Chairman, I'd have to get those numbers. I think we presented them I have them right now. Since 2009, Mr. Chairman, our office has received 18 requests to construct new nursing homes or beds. 11 have been approved and 7 were denied, again, by the language that's in the statute. Your last question is harder to answer. What will we see if this were repealed?
Wait a minute, I think I just heard donuts calling for tomorrow. Go ahead and proceed, sir.
Mr. Chairman, I don't know. It's really hard to project what would happen. So we can hypothesize on both sides of the coin of will we see new market entrants if certificate of need is repealed, meaning new companies or entities come in to construct new nursing homes in Wyoming. I don't know. I think it could be a mixed bag. If I had to guess, I doubt we see an influx of additional nursing homes being built. It's as we all know, with all the policy and regulatory environment that goes with nursing homes, it's not the easiest area to manage as an industry. But I don't have a definitive answer for you. If this was repealed, would we see additional nursing home construction in the state?
Mr. Bully, comment.
Mr. Chairman, on that question, though, and I think one of my members is online and wants to testify, but a similar thing took place in Utah in 2017, where there was a moratorium put in place on additional beds, and that was lifted. What they did see is there were 9 new facilities that were built that were Medicare only, which actually damaged the existing nursing homes because it took the higher payers, and it ended up costing the state more money because what you end up with is unsustainable Medicaid only nursing homes. And I think that Nancy Bunat's online and can speak to that when the time is right. But there are some concerns that similar to what we see in hospitals. Without that certificate of need, we see surgical centers, we see freestanding imaging centers, we see other things. And we're going to talk about this being free enterprise or free market. But really, realistically, healthcare is not your traditional free market. What you end up doing is you have entities that come in and they pick the cream of the crop and they make a lot of money. And then you have your safety net facilities that end up taking the brunt of that, which actually drives up the cost of healthcare because they become more unsustainable. And so I just have some concerns about a complete repeal at this point. And I'll have further testimony, but anyway, that was the Utah example, is that they actually just saw new construction on Medicare only, which actually drove the cost of healthcare, long-term care up in the state of Utah.
Let's go ahead and let her in to testify real quick if we could. My co-chair is left and you'll have to let her in. Nancy, I believe, is that correct?
Yes, that is correct. Can you hear me okay?
You bet. Go ahead and introduce yourself and go ahead and talk to us.
Yes, thank you, Mr. Chairman. My name is Nancy Bunat. I'm the administrator at Rocky Mountain Care in Evanston, Wyoming. I've been at that facility for 15 years now. The facility has maintained a 5-star quality and a 5-star overall rating. Just for some information of the committee, my current facility is a 60-bed facility, licensed for 60 beds. The current occupancy level is 72%. You're probably aware the population in Evanston is about 12,000 and in our county about 20,000. So we are the sole provider of skilled nursing facility and nursing home services in Uinta County at this time. So currently, we've talked about the statute as it reads currently, that nursing care facility beds should not be expanded or constructed if the average occupancy in the area is 85% or less. So my viewpoint is that I would like to see the certificate of need be continued with a modification to the current program. And I would like to see more discussion and, more consideration on the topic. So as Mr. Boley mentioned, the state of Utah, where our corporate office resides, and I spend a lot of time with my cohorts in Utah. They had similar concerns a number of years ago, and they decided to continue with the moratorium on those SNF beds. The reason, as Mr. Boley described, was that many Medicare-only buildings popped up and took a lot of those patients that would normally reside in a facility such as mine, took those higher paying residents or those higher paying patients, and then shifted the cost to the long-term care facility and took away the ability to cover the costs with that higher paying Medicare dollars. So one of the things I would ask to consider as well is the staffing. So if we were to allow nursing homes and facilities, rehab facilities to pop up, we are already in a severe staffing shortage in my industry. By allowing others to come in, it creates new jobs, but it doesn't increase the number of staff that I can pull from. We know nurses and CNAs currently are at a premium, and by asking or inviting others to come in, we would be exacerbating that staffing problem. So a little bit about when we talk about the ability for facilities to refurbish or renew their existing facility or to add on. At our facility, we are not for profit and just completed a large renovation. I believe the total is about $8 million currently to renovate resident rooms, provide private showers in every patient's room, increase the number of private rooms, put in a new HVAC system for resident comfort, put in a new fire sprinkler system for resident safety. So we've been able to do some things to make the facility a nicer place without having to build on. Currently, Wyoming occupancy is about 65% in facilities such as mine. I would anticipate that would continue, especially if the federally mandated minimum staffing requirements that have been discussed by the Biden administration, if those come through and are approved in the next 3 to 5 years, it exacerbates our staffing problem, but also could significantly decrease our ability to take additional patients. As Mr. Boley described, we are not a free market system. So government programs such as Medicare and Medicaid, they dictate what we will be paid for a patient, and they dictate basically who can and cannot enter the building. Thus, they control the supply of beds. I, as the operator of the facility, cannot raise rates to make up for the lost revenue that could be experienced if another facility were to come into our town or any other town in our state. By repealing the certificate of need, it could create less competition. Facilities could just choose to go out of business because they can't find staff or they can't find residents to fill these beds. There's only so many people that need the services that we provide. Of course, we anticipate as baby boomers age into our system that we may see a few more who need it, but the state continues to pay us a fixed amount. And we have plenty of competition now. If we're only at 65% occupancy across the state, that tells me that either we're losing patients to other states or patients are choosing to stay home longer under some community-based services and community-based waivers. So I think currently about 44 states have restrictions on the growth of nursing home beds. Utah, as was mentioned by Mr. Boley, decided to put a moratorium after they lifted it. The moratorium is now in place. They don't allow any SNF beds to be built at the current time. I also feel like there should be an incentive for the existing high-performing facilities such as mine to reinvest into capital projects or to improve the overall quality of life for residents. So I would ask in conclusion that we continue with the certificate of need or make some modifications to the current program and have some more discussion on the topic. Thank you for your time.
Thank you. Question, Representative Penn.
Thank you, Mr. Chairman. Mrs. Bunot, can you spell your name for me? that's not my question, but
Yeah, my last name is Bunot, B-U-N-O-T.
oh, okay, I
Yeah,
got it
that
right.
counts
Okay.
as one question. Go ahead.
You said that your occupancy was 72%. Could you help me understand why that is? If you're the only facility in Uintah County, is it staffing? Is it, tell me why you're only at 72% instead of higher than that?
Yeah, so it's a
Go ahead,
function.
ma'am.
I'm sorry, Mr. Chairman, am I good to proceed?
You go ahead. You're free. Go ahead and answer that.
Thank you. So currently, like you mentioned, the 72% occupancy, it's a function of a couple of things. Most recently is a function of our staffing. We have many, probably about 10 FTEs open that if I were able to fill a number of those, I could increase my patient census to probably about 85%. And then, it's just a matter of, I do believe in our location in Evanston, we do lose some to the Wasatch Front. We lose some to Salt Lake City and to other areas that might choose, to be there where their families or other people are residing there in the state of Utah.
Further questions? Yep. Well, there's two of them down here. Representative Ward.
Thank you, Mr. Chairman. Mrs. Bunot, have you now or have you ever required vaccination for your staff?
Mr. Chairman.
Ms. Bunot.
Yes, I will answer that. That was a federal mandate that came across from Medicare services. And because we have a license for Medicare and Medicaid, that was something that was required at one time during the COVID pandemic. However, we did offer for those staff members who decided not to become vaccinated, there were options for them to do a religious or a medical exemption to allow them to continue to work without having received the vaccine.
Follow up, Representative Ward.
Thank you, Mr. Chairman. Were all of those granted? Number one, and number two, do you still require vaccination? Thank you.
Thank you for the question.
Ms.
Mr.
Bunot, go
Chairman,
ahead.
the answer to that question would be, number one, I believe you asked if all of those were granted. Yes, they were. All the religious and medical exemptions that were granted or that were requested were granted. And number two, your question about does that still remain in place as a requirement? No, it does not. That is something that the Centers for Medicare and Medicaid Services has repealed or revised since the COVID pandemic.
Representative Warnock, you got something? Nope. General question on the bill. Okay, we'll hold off. Any more questions from Ms. Bunot? Oh, go ahead, Representative Penn.
Thank you, Mr. Chairman. Mrs. Bunot, you said you may have some suggestions on this bill as it sits before us. It sounds like you're against a total repeal, but you said maybe you have some suggestions. Would you offer those?
I would, like I said, I would just like to see some way that we could allow for high-performing facilities to expand when the need is there. Allowing for those, those that are doing a good job to continue to do a good job and to allow them to expand without hindering or, bringing in additional facilities that would cause a high performing facility to close down or to close wings. So I would like to see some sort of incentive or some sort of allowance for high performing facilities to do some of these things, expanding, building on, creating new rooms, new beds, those types of things.
Thank you very much. It sounds like it's a topic of a discussion that probably doesn't fit into our bill draft that we have, so. Okay, any further questions? Mr. Boley, further comment?
Mr. Chairman, I would just tell the committee that Ms. Bunot is one of the best nursing home administrators in the state. She does a fantastic job, and you can tell from her expertise that she really cares for those that she serves in her community. So I appreciate her comments. And I echo some of the things that she said. So as we talk about occupancy rates in the state, around 65%, and most of it is a function of staffing. There is demand out there, but there's no staff. And we're going to talk more about long-term care issues later on today, but there's a new mandate that's been proposed by CMS that are going to put minimum staffing levels in place for all nursing homes. It's going to decimate long-term care. We'll see closures in our state if it's fully enacted. I think along those same lines with suggestions, and this is why I think it might make sense for us to take this to the interim and take a look at what we can and can't do. I do believe we should build quality measures into expansion of nursing homes. There is a survey process, and nursing homes go on special focus under the licensure Office of License and Survey. But I think a complete repeal at this point, it's really hard to put it back in place. I just really think that there are lessons to be learned. I would tell you that other states are actually considering reinstating certificate of need where they've been repealed. I just think that it's premature at this point. The reason that this was brought forward is during the pandemic, when the ARPA funding came out, some of my nursing homes really wanted to use that ARPA funding to create private beds for all of their residents and maybe expand their footprint. But because of the limitations that are put on here, they could only do up to 10% of their beds with a cap at 10. It just didn't make sense. It's like, I was hoping to actually maybe get this looked at so that we could get some funding in place to help with some of the great projects like they did at Rocky Mountain, where they made private beds with private showers, which is, I think, what we all want when we're in long-term care. I just think that this is a very, very vulnerable and at risk long-term care in our state. I would just hope that we could take a more measured approach. I'm not opposed to looking at this, but I don't think we've spent enough time, and I don't think that we've learned from the examples of surrounding states. There's a reason that 44 states or 40 states have certain things in place to protect long-term care.
Questions, Representative Penn?
Thank
I
you.
just looked down there now because I know it's going to be green. Go ahead.
Thank you. Mr. Boley, is there, I'm just still, you kind of answered it a little bit in what you just said, but I'm still wondering, is there an impetus for why now? Like, do we know if there's any facilities that are attempting now to build? You mentioned the ARPA stuff previously, that this is coming out at this time.
Go ahead, Mr. Bullock.
Mr. Chairman, Representative Penn, so I am aware of some that have considered expansion of their beds, but because of the limitations that are put in place, they didn't even apply for them. I actually believe that if I remember right, there was one in your neck of the woods in Fremont County that looked at expanding and decided that the juice wasn't worth the squeeze because of the limitations that are in place. And so I think before we repeal the whole thing, maybe there are some things we can do. And I think we could work with the Department of Health to come up with some better ideas on how we could incorporate quality measures. And I know you're going to hear from one of my hospital members that is interested in the repeal because of things that are going on in their community. And I believe that residents deserve the very best care that they can receive. They're super, super important. But I just really worry about how fragile these nursing homes are right now, and it's only going to get worse. And we'll talk a little bit more. I went through the Department of Health's presentation and looked at the bump that took place in long-term care with Medicaid funding. They went a decade frozen or with cuts in places. So that's the first significant increase that they've seen. And even with that, we're still not covering the costs of delivering care to the Medicaid patients. It's going to help, but we can throw as much money as we want at the staffing issue, but until we find bodies, it's not gonna fix things. And we're going to be facing some major challenges with the new CMS guidance that's come out with staffing levels.
Further questions from Mr. Boley? Go ahead.
Thank you, Mr. Chairman. Mr. Boley, one of the things I concerned with the current rules is the mileage. If my small town's 25 miles from a larger town that has nursing home, my small town can't build a nursing home, right? So if I want to see my dad, I have to travel 50 miles a day to go see my dad, or vice versa. If I'm in a larger town that needs to expand and there's a small town that has lots of open beds, we can't expand in the larger town. So when you look at some of these other states, is that mileage part common? I mean, do you see it being 10 miles or 5 miles or 15 miles, something like that?
Mr. Chairman, Representative Clauston, I haven't done a deep dive into this, but it's all over the board. I mean, each of the different states have different guidance within those, because actually there is some leeway as far as how it's structured within the state. I think that's one of the things we could definitely look at, though. And I think it makes sense. I agree with you. It's nice for our aging population to be able to age at home and be where their family and where their friends are. And to my knowledge, honestly, when I take a look around the state at the nursing homes that have been built in the 30 years I've been here, we haven't really run into any snags, because normally it's the hospitals that are building those in their communities but if you look at those that are supported by their hospitals, most of them are being subsidized in your community. It's over $2 million a year that the hospital is subsidizing to keep the legacy open. And so what will happen with the market, I don't know. But if we take a look at experiences in other states, it looks like we do have some cherry picking, which will only drive up costs and put these safety net facilities at risk.
Representative Warnock.
Thank you, Mr. Chairman. So I've actually constructed some of these facilities and you know, ran into this where the developer wanted to build a much bigger facility, but could not because of these kind of limitations. I also know a current personal example where, you know, in the family, we are trying to get somebody into a care facility and it's a 2-year wait. So we've got, and I understand we've got some issues with staffing and I mean, that's a major problem right there. But on the private side and on a waiting list, wouldn't this help solve some of those problems that we're running into for citizens of Wyoming wanting to put their elderly parents somewhere, or the mileage issues or something? Wouldn't this help ease some of that burden?
Mr. Boley.
Mr. Chairman, Representative Hornick, my opinion is no. Building a new facility is only going to put more stress on an already fractured system. You're going to be fighting for the same employees. And so what you're going to end up with is nursing homes that have even less occupancy and they become less viable. Realistically, for a nursing home to even be viable, especially those that serve only private pay and Medicaid patients, you've got to be around 90 or 95% occupancy to be viable. There are not employees out there to be had. So we're going to build a bunch of beautiful brand new facilities and we're going to be fighting over them. A great example, honestly, and Director Johansson's probably staring at me right now. The state was able to construct a VA nursing home up in Buffalo. And we warned them at the time that it's going to be really hard to staff that. And countless debates went on about it. We've got a beautiful greenhouse VA nursing home up in Buffalo that can't be fully staffed. And we've spent millions and millions of dollars on it. And on the flip side, we have the hospital district that built a 45-bed nursing home up there that's almost brand new too. One of their wings is closed right now. It's not because there isn't demand, like you're talking about a family member, it's because they can't staff it. There is not enough workforce right now really to sustain those. And so kind of what happens, and I'll go back to my hospital side of things. What happens in hospitals? We see surgical centers that come in and they build in our communities and they operate for a few years and they only take the highly insured, the high payers, and the rest of them go to the community hospital and they're paid Medicare or indigent care. And before long, that surgical center wants to partner or come under or sell to the hospitals. That's exactly what's probably going to happen here is we're based on the Utah example is you're going to have those that come in and they take the high payers and it's going to leave your safety nets vulnerable and without. But if you need some help getting somebody in, let me know. I can't believe there's a 2-year wait in Wyoming, but if there's something I can do to help you get a family member in, just give me a holler.
Question, follow up.
Yeah, thank you. So how are we not, you know, limiting some of our private enterprise because of a different problem? I understand we've got a staffing problem in Wyoming, but if that weren't part of this picture, you know, aren't we hamstringing one problem because of another problem that we can't staff these facilities? So if we could staff these facilities, and granted, there's a lot to that with pay, with the number of people in Wyoming, I fully understand that. But if we didn't hypothetically have that problem, wouldn't this help generally in our long-term care needs here in Wyoming for citizens?
Mr. Boley.
Mr. Chairman, Representative Hornick, I think that's a great question. And the one thing to realize is that the staffing shortage we're facing here, we're facing it nationally. And with the new mandates, we're going to need 200,000 new workers to fill the needs for long-term care. As far as your question about if we could staff it, what would that mean? I think that's where certificate of need kind of makes some sense. If the existing facilities are at the point where they have high enough occupancy, it proves demand for another one in that community. I think on your previous example, though, I do think there's some tweaks that could be made. So if there is new construction going on, maybe we can remove some of the barriers so that when we're in the middle of building, we can do it with economies of scale and save them some money. And that's where my heartburn comes from, is if you're limited to 10% of your existing beds, up to 10 beds, and you want to build a greenhouse pod, which is 12, you can't do that. It doesn't make sense. So I think there are some things we can do to the existing statute that would allow us to build those economies of scale and to save the facility money. I just think that we're a little bit premature in repealing. I really think we need to look at it more and spend some more time on it to make sure that whatever we do meets the needs of our state and meets the needs of those that need that care.
Okay, further questions for Mr. Bowley? Seeing none. Oh, Senator Dockstader.
Thank you, Mr. Chairman. Mr. Bullock, do you have any idea how many facilities we have that are tied into their hospitals, nursing care? And
Mr. Chairman, Senator Dockstader, I think it's around 12. And then when sublet's built, it'll be 13. This one actually, we might have 14 now.
And in summary, Mr. Follow-up, Mr. Bullock, your association is opposed to this legislation?
Mr. Chairman, Senator Dockstader, Leading Age Wyoming, we are opposed to this, yes.
Further questions for Mr. Bowley? Representative Penn.
Last one. Thank you, Mr. Chairman. Do assisted living centers classify as nursing care facilities? No.
Mr. Chairman, Representative Penn, they don't.
Okay, further questions, committee? Seeing none. Thank you. Do we have one more person online? I thought.
Not currently.
No, nobody else online. Okay, committee, I heard a number of things about this bill.
Public comment.
Public comment. Oh, I'm sorry. Welcome. Hey, turn your light on there, Carolyn.
Yeah, I don't even know. There it is.
There you go. Welcome.
I agree. Chairman Baldwin, Carolyn Passano with the Wyoming Healthcare Association. I agree with Nancy Dunat and with Mr. Bowley a great deal. Didn't know that I would stand up, but there's one thing that has not come forward, and it is what's happening at the federal level. And of course, if you take federal dollars, you are a captive of the federal government. And they do have mandates, and you'll hear more about that this afternoon with staffing. And when they are in charge, we follow what they're telling us to do. And if you look at what has happened in the last few years, the Federal Reserve actually tried to solve, or at least forestall, what was going to happen with inflation. And that got us into $1 trillion in debt. And I just read some research, some gurus who are saying that by the end of this year, and perhaps not until you meet in February or so, that is actually going to rise to 2 million. We are in trouble. And thinking about what that pressure is going to do to us. I think it's wise not to go forward with this project or this proposed bill at this time. We might want to look at it down the road because we know that we have according to A&I, an influx of elderly people that are going to be needing the services in the future. It is, as Mr. Bowley said, premature right now, I believe. And talking with the people who are in running the nursing homes for Wyoming Healthcare Association. And I would actually suggest at this time that there is a task force put together and look at where we are and where we want to go in the future and how we would get there with, if we ended up in America with a $2 trillion deficit, what that will mean for us in this state. We know that for the Medicaid ratio for Wyoming, it's a 50-50 match. If we didn't have Teton and Jackson, it would be a 60-40 or maybe even better. You know, there's all kinds of little legs that go off from this subject. And with that, I know we're running a little late, so thank you for your time.
Questions for Ms. Pasno? See none. Thank you very much, Carolyn.
you.
Pleasure to see you here. Anybody else wish to comment? Come on up, sir. Welcome to Labor and Health. Introduce yourself and
Thank you, Mr. Chairman and committee. I'm Gary Crum from Laramie, Wyoming. Appreciate your time, and I know I'm probably the only guy between you and lunch, so I'll make it quick. I want to speak in favor of repealing the statute, and here's why. A couple things as we get going. I want to tell you a couple quick stories, and I do appreciate the nursing homes position on wanting to protect what they've got now. But for the people of Wyoming, we need more beds, and it may not be true in every town, but it's certainly true in Laramie and our surrounding community. Cheyenne, I know, has some issues, and we did hear that because of the quality, people are leaving the state to go to where there are adequate nursing home facilities. So I just as soon keep those people in the state. But some quick stories. My father and mother-in-law were in nursing homes, and they both have passed away. But my father was in Laramie's nursing home, went to pick him up one Sunday to go to church. And he's sitting on a couch out in the hallway, half dressed, shirt crooked, and that type of thing. The week before, he was, had his coat and tie on, and he was ready to go to church. Sitting in a chair, I said, "Dad, are you okay?" He wouldn't look at me. I got on my knee. I said, "Dad, are you okay?" And just kind of grunted. I went to find a nurse, and I found a nurse. She was delivering daily medication to patients. I said, "My dad's sitting in a chair. Can you help me? We need to get him to a hospital." She goes, "Well, when I get done delivering these medications, I'll come help you." And that was obviously not the answer I was looking for. So I went and got my dad, put him under, he couldn't really walk, but I picked him up and was carrying him out the door of the nursing home. She says, "You can't leave." And I said, "I'm going to leave." She goes, "Well, I'm going to have to call the police." I said, "Good, call the police and meet me at the hospital." Like, by the time I got him to the hospital, he's completely incoherent. He lasts about another 2 weeks and passes away. But my mother-in-law, she was up in a nursing home in Montana, very similar situation. However, she got to that point, got her in the hospital, got her back to the nursing home. And for the last about 30 hours of her life, there was a person from the nursing home, a nurse, that was with the family and with her the whole period of time as she transitioned and passed away. And the big difference that I can see is there was competition. She was in Helena. There were several nursing homes, and the nursing homes were well kept, well taken care of. Well, the Laramie nursing home at that time smelled like urine. You walk in the door today, it smells like urine when you walk in the front door. I know they try to clean it, but at the end of the day, they don't spend the money on the facility they need to make it what we would all expect to be there. And and the reality is all of us are going to end up in a nursing home. The odds are that we get there one day to spend a little bit of time in a nursing home at some point in time. And I would think that we don't want that. I do believe competition is good. It is a different marketplace being in healthcare. But I do believe competition brings out the best. As we heard right now, a current nursing home that was totally successful has a struggle even to expand under this current situation, because they can expand, I believe it's up to a maximum of 10 beds or something like that. So the bill is, or the statute right now just is inadequate as we're out there. Staffing, I've been in business for 40 some years. Staffing is just a matter of you've got to find the right people, recruit, and you're going to have to pay the people what they need to be paid to get them in there. Staffing is a matter of choice, in my opinion, whether you can get people in there or not. So I would strongly urge this committee to repeal the bill, improve long-term nursing care in this state, and it will take care of itself. So with that, I do appreciate your time and your efforts on this situation.
Thank you, Mr. Crum. Questions, Mr. Co-Chair?
Thank you, Mr. Crum. You're here as a private citizen today.
I am here as a private citizen. As Mr. Bully said, I am on the board at Ivinson Hospital, but I am not representing Ivinson Hospital. I have no vested interest in anybody. I am a banker. And I do know of several organizations that have thought about starting a nursing home, at least in the Laramie community and in the Rollins community, but due to this law that they've been unable to do so.
No, I mean, you're a former CEO, you're not just a banker, but I just really appreciate you coming as a private citizen to testify in this.
Yes.
Okay, further questions for Mr. Crum? Go ahead, Representative Yin.
Mr. Chairman, Mr. Crum. Does Montana not have a certificate of need program? Because I mean, I'm just Googling, and so I don't know if this is correct. It seems that they do. Is that not correct?
I'm sorry, I didn't get that.
Does Montana not have a certificate of need program?
Go ahead.
I'm not familiar with Montana laws. I just know that Montana, there was competition up there, and the nursing homes were in much better condition than the nursing home in Laramie or Rollins, which I'm really familiar with.
Further questions for Mr. Crum? Seeing Mr. Crum, are you related to somebody from Rollins, perhaps?
I am from Rollins originally.
Personal question. Gary would be related to you.
Yeah.
Very good. Okay, I'll talk with you offline.
Okay.
Okay, further questions for Mr. Crum? Okay, thank you very much for coming to see us today.
Thank you, Mr. Chairman and committee.
Okay, anyone else wish to testify to this bill? Oh, can you turn that light off for us? Thank you. Anyone else wish to appear before the committee? Anyone online? No one online. Committee, thoughts, ideas, what you wish to do with the bill? A hand, Representative Warnock.
Thank you, Mr. Chairman. I do have a question first for the department, if I may. I'm curious what they do now. Is there an entity within the department that approves or denies these expansions? And why were they mentioned, I believe, 7 denials in the last year or 2 or whatever? I'm curious why those were denied.
Okay, Director, go ahead, sir.
Mr. Chairman, Representative Hornock, first answer your first question is yes, my Office of Healthcare Licensing and Surveys runs or manages certificate of need applications. And then of those, the 7 that I mentioned were denied since 2009 would be because of the provisions that are listed in statute. So the occupancy of all nursing home beds within that geographic radius that's listed in the statute would be the primary reason for those denials.
Okay, comments, committee, suggestions, ideas. Representative Warnock, I got to look more to my left. I'm sorry. Go ahead.
Quite all right. So just to follow up, if this were not in place, if we didn't have the certificate of need, then it's safe to say that those applications would not have then been denied.
Mr. Chairman, Representative Hornock, they would not have even come in if there was no certificate of need law. So we would not have been involved in reviewing, approving, or denying expansion applications. The only caveat I'll add to that, which is not related to certificate of need, but healthcare facility construction is also under the auspices and regulations of the Office of Healthcare Licensing and Surveys. So again, not a certificate of need or an occupancy issue, but in terms of reviewing and approving construction plans, life safety code, conducting annual surveys, both on behalf of the state and on behalf of CMS, should the nursing home be CMS certified, then we would still be involved from that perspective.
Thank you, Mr. Chairman. And that structure is already in place. I do know that having built healthcare facilities, there's special regulations that you have to meet just in design and that kind of stuff. So those are already in place there, right?
Mr. Chairman, Representative Hornock, yes.
Okay. Committee, once again, comments, move up. The green light is still on. Go ahead.
Thank you, Mr. Chairman. I would like to offer an amendment, actually.
We got to move the bill first. It hasn't been moved yet. Bill has now been moved by Representative Ward. Would somebody like to second that?
I'll second.
Okay, it's seconded. It's on the floor. Go ahead. Your amendment idea, sir.
Thank you, Mr. Chairman. So the amendment would be on page 2, about the middle of page 2, paragraph A, that the contemplating construction, you're supposed to submit plans and specifications of the division for preliminary inspection and comment. I'd like to change the word approval to comment. So it seems to me like the department already has, or you know, if this is repealed, they will not be able to deny applications. So I would like to, I think it's important for them to have the ability to offer comments to this. So just changing that one word.
Can you just once again tell me the page and the line number on that one, Representative?
Thank you, Mr. Chairman. Line 24 on page 2. Change the word approval to comment.
Okay, committee comments, concerns? Representative Yen.
So, Mr. Chairman, is this no longer repealing and then just amending existing statute?
An amendment to existing
Right.
statute 35-296.
Okay, so then it would just not be a repeal bill anymore. It would just be a bill that amends the current
Correct.
certificate of need program.
Further comments, questions, thoughts?
Well, let me just make.
Go ahead.
We're still repealing the rest. We're just adding in the commentary. So instead of a straight repealer, there's an amendment to current law and then existing repealers, because 35-296A is not being repealed. We're just, that's correct, LSO? Okay.
Okay. Any further comments? Question on the amendment? All those in favor say aye.
Aye.
Opposed, say no.
No.
That amendment passes. Oh, Anna, go ahead, ma'am.
So, Mr. Chairman, there's also another word that probably needs to be changed because it says approved prior to implementation. That's on line 26, sorry.
Yeah.
And
So maybe commented on.
Mr. Co-Chairman, I think we would just say that amendment, if there's anything else in that statute that is a similar mindset to conforming amendments to happen. And if you'd review one more time, anything else in the statute, right? In 35-2.
Let's just be official on that one more time. Let's take a vote. I believe we heard a bill. All those in favor of that amendment, say aye.
Aye.
Opposed, say no. That amendment has passed. Further amendments, further thoughts, discussion committee. Seeing none, let's do a roll call on that, please.
I'd like to offer just a short statement on the bill.
Okay, a short statement on the bill. Go ahead, Representative Ward.
Thank you, Mr. Chairman. I think it's truer words have never been spoken that we don't have a free market in healthcare. It seems that those are currently in this field are requesting that we protect their monopolies. I know for a fact that a significant portion of healthcare workers have left the field permanently because of the draconian requirements for vaccination during this pandemic. For that reason, it's difficult for me to be sympathetic when staffing shortages are now a reality. We need to move toward a freer market. For that reason, I'm a yes on this proposal.
Further comments, statements? Okay, we'll go back to roll call. Okay, you go ahead.
Mr. Chairman, this is roll call for 24 LSO 0151, Certificate of Need repeal as amended. Senator Barlow. Senator Bouchard,
Excused?
Senator Dockstetter. Senator Hutchings. Representative Chadwick.
No.
Representative Klauston,
Aye.
Representative Hornock,
Aye.
Representative O'Hearn,
Aye.
Representative Penn,
Aye.
Representative Trujillo,
Aye.
Representative Ward,
Aye.
Representative Yen,
No.
Co-Chairman Swanser,
Aye.
Chairman Baldwin.
No.
Eight aye, 4 no, 2 excused.
Committee, that bill is passed. It will be sponsored by our committee in the upcoming session, coming sooner than we think. Okay, it's 12:33. We will be back here at 1:33. We're a half hour behind our schedule. We will attempt to catch up when we come back. There's multiple places to eat in town. If you look hard enough, we'll see you back here at 1:30. Okay, we're adjourned to 1:30.